thank everyone for joining us for the Children at Risk and Texas Family Leadership Council's 150 Miles Health in the Borderlands. And we're really excited to examine the challenges and innovations that impact communities along the border. As most of us know, the Texas-Mexico border lies along the Rio Grande and stretches about 1,254 miles, according to TxDOT. And along the border, there are 28 international bridges and border crossings to allow commercial, vehicular, and pedestrian traffic to cross. Another thing to note is the Department of State Health and Human Services defines the Texas-Mexico border area as a geographic area within 100 kilometers or 62 miles north and south of the international boundary of the Rio Grande. And this was established by the La Paz Agreement in 1986. So this vast area of 1,254 miles encompasses actually about 67,557 square miles and includes 32 Texas counties and Mexico. While the border-defined region only stretches about 62 miles into the Texas, security points can be found as far as 150 miles inland from the Texas-Mexico border. So, for those living in the border communities, these checkpoints are just a part of everyday life as they travel to work, school, and daily activities like doctor's appointments or shopping, including grocery shopping. So as we reflect on health and practices on the border and in all border areas of our state, we encourage attendees to not only listen to the challenges these communities face, but quite frankly, to be inspired by those innovations and those individuals and guest experts who capitalize on the need to truly meet their community where they are. I am so excited. We have such an exciting array of presenters today, and we hope that this convening can encourage you and help you grow help us as advocates, service providers, and community members. For those of us living in a border community, checkpoints and border life is every day as we travel back and forth and the daily activities that we reflect on. So before we get started and before we bring in our first presenter, our first speaker, I want to go through some housekeeping notes. So, and you have them in the chat, but please use the Q&A or the chat function to ask questions or communicate any technical difficulties. Also, we're very, very excited and grateful to have the support of the Michael and Susan Dell Center for Healthy Living. And we're offering 2.5 advanced level CHES, MCHES credits for this summit. So if you did not select the option to receive these continuing education credits during registration, you can use the link that's also in the survey link in the chat to share your information with the staff from Children at Risk. So, and of course, I would be remiss if I didn't take the opportunity to thank our sponsors for today's conference, and that includes Amazon, Methodist Healthcare Ministries, and the UTHealth Michael and Susan Dell Center for Healthy Living, and of course the partners that have worked on these presentations and on gathering all this information and speakers for today's session. United Way of El Paso County. I see the word United Way and I say El Paso County, but I want to start with United Way of Southern Cameron County, the Boys and Girls Club of McAllen, Paso del Norte Health Foundation, Action for Healthy Kids, Doctors for Change, MHP Salud, and Valley Baptist Health Center, and of course, United Way of El Paso County. So with that, I think we are ready to begin our presentation. So I am very, very excited. And you have the bios of the speakers in the chat box. So I'm really going to encourage you to read about all these wonderful, wonderful speakers that we have. But it's my special privilege to introduce our first speaker, and it is Commissioner David Stout. And Commissioner Stout is the County Commissioner in Precinct 2 in El Paso County. And I must say, proudly that he is also involved with our United Way here in El Paso, Texas, and serves on the advisory board for our Family Resiliency Center, which is the effort that is taking on the long-term healing of our community after our August 3rd, 2019 mass casualty event. So it's my pleasure to introduce Commissioner David Stout.
Thank you. Thank you so much, Deb. Good morning, everybody. Thank you for inviting me to be here and to share a few words with you. As Mrs. Zuloaga said, I am the County Commissioner for Precinct 2, which is pretty much central El Paso. I have the only precinct that is wholly within the city limits, and it includes wealthy neighborhoods to the northwest and northeast, as well as central and one of the lowest income zip codes in the nation, which is 79901, which is south and east of downtown El Paso. While we have many well-known issues with colonias in the county, we have urban needs south of I-10 as well. And yes, we are, of course, a border community, the largest sister city combination of municipalities. And if I may use a coined phrase from a couple of years ago, the capital of the border. More broadly, as an overview to set the stage for this conference, the Texas border makes up about half of the US-Mexico border. The Texas-Mexico border includes the two countries and of course, two tribal nations as well, creating tri-national regions. The Kickapoo traditional tribe of Texas near Eagle Pass and the Isleta del Sur Pueblo here in El Paso County. Within Texas, this includes 32 counties bordering 4 states of Mexico. There are 8 sister cities from El Paso, Ciudad Juarez to Brownsville, Matamoros. And we have approaches to local issues on the border, in border communities have to be taken with international perspective, in my opinion. US-Mexico Border Mayors Association serves as an advocacy voice for the communities that they serve and the residents who have ties on both sides of the border. And part of this charge includes collaboration to achieve a healthy border focused on disease prevention and of course, health promotion. Policies affecting the environmental factors such as air and water and infrastructure, like hospitals and roads made on one side of the border have implications on both sides and for many generations. Healthy children are the future. Our workforce, doctors, teachers, engineers serving our communities, the border counties and cities, if not in the whole, at least in part, qualify as medically underserved areas, which means there is a shortage of healthcare professionals, ranging from doctors, nurses to dentists, therapists, to meet the needs of those who live here. A few stats for El Paso County shortage when it comes to our medically underserved area. About 2,000 to 1 physicians, about 2,000 people to 1 physician, about 2,100 people to 1 dentist, and about 1,000 people to 1 for mental health care professionals. For Hidalgo County, 2,100 people per physician, 3,600 people per dentist, and about 1,500 people per mental health healthcare professional. Social determinants of health, such as income, education, housing, and other infrastructure, make this area vulnerable to poor health. In Texas, COVID death rates for border residents younger than 65 were nearly 3 times the national average for that age, and more than twice the state average. 23% of all persons in the Texas-Mexico border counties are living under the federal poverty line. 25% of the people in border counties lack health insurance. Among employed people, the lack of health insurance is even higher at 33%. So these challenges have given rise to many innovative approaches to addressing issues of need and their planning and cooperation among many players that can serve as examples for the rest of Texas and the country. During the rest of the event today, you will get a small picture of the strengths and opportunities in health and well-being for the border and the rest of the country. And again, I really appreciate the opportunity to help set the stage this morning for you and for what you will hear. at this really, really important event. I want to thank Anna Briones, Sharmily, and the entire Children at Risk organization for the work you do. Thank you to Deb Zuloaga, who is an amazing advocate for many, many things here in El Paso County. You know, thank you very much to all of you who are attending. I hope you have a really, really great conference.
Thank you, Commissioner Stout. We appreciate you joining us this morning and giving us these really great opening remarks. And we know you have a busy day, but we hope you can stay for at least a part of today's session so that you can also contribute questions and give us comments on things that you think are important to all our communities, because we're all one state and one community. So with that, I just want to remind everybody that you can put your questions in the chat box. And so I'm really excited to introduce the first group of speakers, the first panel. And I am going to, it is called, let me make sure I'm looking at this correctly, I apologize. It is Spanning the Border and Beyond, and it's an overview of children's health and nutrition. And it is Dr. Deanna Hoelscher, and she is the Regional Dean of UTHealth School of Public Health in Austin, and Director of the Michael and Susan Dell Center for Healthy Living. And we're really excited to welcome her and have her speak about the border and the health and our overview. So thank you very much, and I'd like to welcome her.
Great. Thank you so much, Deborah, for that introduction, and good morning to you all. I'm glad to be here today. So what I'm going to talk about today is some of what we've done with SPAN and data that we have that's specific for the border on kids' health. So next slide, please. I'd just like to introduce our center. We're the Michael and Susan Dell Center for Healthy Living. You heard a little bit about us previously, but our vision is healthy children in a healthy world. And we know you can't have healthy children without healthy parents and healthy communities. So it kind of extends beyond the child itself. Next slide. So Texas SPAN is the Texas School Physical Activity and Nutrition Project. And so SPAN was started in 2000. So we've been doing this for over 2 decades, but it's a surveillance system that monitors the prevalence of trends in overweight and obesity in school children, but also factors identified or associated with obesity. So nutrition and physical activity. We also look at oral health. So the last time we did SPAN was in 2019, 2020, and we stopped on March 13th. So these data are immediately before the pandemic. So I want you to keep that in mind as we go along, because if there are changes, I think they've probably gone in a more negative direction, if I had to guess. So one of the things, though, that we were able to do is we were able to get our Texas-Mexico border non-border so that we could apply sampling weights to that. So that enables me to show you those data today. Next slide, please. So a little bit about the data that we collect during SPAN, and we might have some partners who've actually helped us collect this, maybe even there along the border. But we collect directly measured height and weight, and we focus on students from 2nd, 4th, 8th, and 11th grades. We differ from some data that you see on BMI in children because we measure the height and weight rather than rely on self-reported height and weight or parent-reported height and weight. We also have a self-report questionnaire that's administered to students of 4th, 8th, and 11th grades. This questionnaire has been validated and we've improved it over the years. And so that kind of shows some of the constructs that we collect data on there. For the 2nd graders, obviously they can't complete a survey like this, so we send a take-home survey for their parents. So when I show you the 2nd grade data, keep in mind it's the parent who's filling that out. And then finally, when we're in the schools, we collect data at the school level, and we also collect data on school policies and practices. So we have a health policy questionnaire that asks about policies at the school. We collect campus improvement plans, we look at vending machines, and then we look at signage there as well. So next slide, please. I just wanted to say a little bit about our sampling design. Didn't want to get too much in the weeds because I know y'all are probably more interested in the data, but it is a multi-stage probability-based survey. It is designed to yield representative data at the state level, the public health region, Texas public health regions, and then at the Texas-Mexico border and non-border areas. So you just heard about this earlier. I think Deborah mentioned this, the La Paz Agreement of 1983, which defines the border counties. So that's what we use as our definition of border counties. So we are able to develop sampling weights so that we can get a representative sample. Next slide, please. So I just wanted to show you our statewide participation. It was a little bit low last year because we had to end early. Generally, we have about 15,000 to 24,000 children who participate. As you can see, we've got from 1,000 to almost 3,000 participants that are surveyed for this, but you can see the population representation when we apply the weights. You can also see that we were in 65 school districts, which are all over the state, and then 177 schools. Just keep in mind when you see these data are on par with what they use in NHANES to extrapolate, to weight those data to the nation. So they're actually pretty robust for a state level assessment. Next slide, please. So I'm going to show you some data on the weight status in the children, but before I do, I just wanted to define the weight categories and the cutoffs that we use for the children. So we use the CDC growth charts, which range from underweight, which is less than the 5th percentile, healthy weight, which is 5th to 85th percentile, overweight, obesity, which is the 95th percentile or above. And then we've also been looking at severe obesity. So that is, the definition for that is 120% or more of the 95th percentile. So roughly the severe obesity equates to severe obesity in adults as well. So the next slide, if you could click one more time, what you see here is you can see the trends of child obesity data in Texas. The second grade students, we didn't add until 2015, 2016. So we don't have the long long trend lines for the second graders like we do the other grade. But 4th grade is orange, the 8th grade is green, and the 11th grade is blue. So one of the things that you see is, especially since 2015, 2016, that the rates of obesity have gone up for all the grade levels. Not so much in 8th grade, but in 11th and 4th grade, we definitely saw an increase. The other thing is the grade 4 data are very interesting. We actually saw a decrease in the prevalence of obesity among 4th graders between 2000 and 2004. It maintained in 2009, and then it went back up again in 2015. So we actually have a significant parabolic trend where it dips down and then goes back up. With the 8th and the 11th grade, we have more of a linear trend. So the black line that's presented there is Healthy People 2030. So that's our goal, is 15.5% prevalence of obesity. So as you can see across the state, at every grade level, we're higher than that. One more click, please. And there you can see the latest data from NHANES, which is for kids that are 2 to 19, and that's a prevalence of 19.3%. So even if you look at where we are currently in the US, Texas kids still have a higher prevalence of obesity. Next slide. So this slide kind of summarizes the prevalence of child obesity, Texas-Mexico border versus the non-border. So the non-border is in blue, the border is in green. So if you look at this, I will kind of, these are just absolute numbers that I'm giving you right now. So we have not done significance testing on them. Generally with these border, non-border differences, what tends to be significant is if you're 7 or 8 absolute percentage points. So I just want to kind of give you a caution on interpreting that right now. But if you look at that, we have a higher prevalence of obesity at every grade level. It's really pronounced in grade 2, grade 4 and 8 is pretty significant as well. Grade 11 is less, there's less of a difference between border and non-border. And then the black line that you see there is where we are within NHANES. So that's the NHANES data that you had seen previously, but just superimposed on this graph. Next slide, please. So this is the prevalence of severe obesity. So this is the Texas-Mexico border versus non-border again, blue for non-border, green for border. And this is very troubling. So if you look at this across the state, we have a prevalence of severe obesity of around 10% across all grade levels. If you look at the black line there, you see the prevalence for the US in general, it's 6.1%. So we're very much higher on at every grade level and whether you're on the border or not on the border. So the prevalence of severe obesity is especially worrisome for all the border grade levels. So this is an area that we really need to look at and see what kind of preventive measures we can put into place. Next slide. So this kind of looks at diet. So we have something called the mean span healthy eating, the SPAN Healthy Eating Index. And so it asks children about a variety of foods that they consume, and it puts them into a scale. So the scale goes from 0 to 100. So 100 would be a perfect diet. None of us has 100. And 0 would be like a horrible diet. So what you can see here is that in general, the mean SPAN Healthy Eating Index is around 40 for grade 2, and it's around 50 for the older grade levels. So this is similar to what you see when you look at US. They use a slightly different scale, but they're around 50%. It is a little bit lower on the border. So you can see that there for grade 2 in particular. The next slide, this is sugar sweetened beverage consumption, and this includes soda, fruit flavored drinks, sweetened tea and coffee and energy drinks. So a lot of sugary beverages. And what you can see there is actually it doesn't look too bad. It's a little bit higher. The consumption is a little bit higher in 2nd grade, but the rest of the grades between border and non-border, it's relatively similar. So here is unhealthy snacks. So these are fries, snack bars, frozen desserts, cakes, donuts, candy, things like that. And so what I've done is I've put rectangles around those grade levels that had more significant findings or that had bigger differences between border and non-border. For grade 2, the border kids consume snacks 3 or more times at a higher prevalence than the non-border kids, but you see the opposite in grade 8. So it's kind of interesting to kind of figure out why that is. Next slide. So this is fruit and vegetable consumption, and this is fruit and vegetable consumption put together. So it's fruit juices, and vegetables all together. And so again, you see what we saw with the snacks, that the grade 2 kids at the border have a higher prevalence of fruit and vegetables. So here they're in the positive direction. And then when you look at grade 8, they're in the negative direction. So they're a little bit lower in the number of of servings of meeting at least three times or three servings of fruits and vegetables on the previous day. So this was one of the most striking findings that we see here. So when you look at this, this is the prevalence of food insecurity among grade 2 families. So the parents filled this out. We do not have these data for the older kids because we did not ask them the food insecurity questions. Not really appropriate in some instances, and especially since this is a school-based survey. But if you look at non-border versus border, you have it's much higher at the border than it is with non-border, which is not surprising and kind of follows up with the remarks that were right before me. If you see that black line, that's where we were in 2020, what USDA had as the national prevalence of food insecurity, which is around 14%. So even at kids that don't live on the border in Texas, they still have a higher prevalence of food insecurity. So this is really households that say they were either worried about food running out or were short on food and couldn't afford more. So this is another one of our more striking findings is we looked at the mean number of days of 60 or more minutes of physical activity in the previous week. And what we saw is there is a difference in the numbers. There's fewer days of the week on average that kids at the border engage in physical activity, 60 minutes a day in grade 2, in grade 8, in grade 11. For grade 4, they're about the same. This slide here shows screen time. And so if you look at the 4th, 8th, and 11th grade, the prevalence of 6 or more hours of screen time, so this is a lot of screen time a day, is pretty much the same. It's pretty much high across, especially grade 8 and grade 11, but it's similar between border and non-border. Where you see the difference is with grade 2. So you can see that the kids at the border have a higher prevalence of 6 or more hours of screen time. Think back about the physical activity. So it's kind of the reverse of physical activity. Next slide. So a little bit about the summary for this. So we know that there are differences in the prevalence of children with obesity and severe obesity in the Texas-Mexico border versus non-border areas of Texas. Part of this, when you look at the food insecurity, there is an association between food insecurity and obesity. Paradoxically, with kids, the association is more nuanced. It's not as robust as what you see with adult women, for example. But there is a certain amount of stress that was mentioned previously, and that can contribute to obesity, as well as some of the behaviors that we saw, physical activity and sedentary behavior. The dietary intake data for the children at the border versus the non-border areas is mixed, but the food insecurity levels, as I mentioned, are higher. And then differences exist in self-reported physical activity by border, non-border status. So thank you. I'd like to acknowledge our funding for this, the Texas Department of State Health Services and the Michael and Susan Dell Foundation. And then one more slide, and that's our team. So we have a lot of people going around the state that help us carry out SPAN. One last thing I'd like to say is currently we are recruiting schools. So we're measuring schools right now, and we'll be in schools in the fall. So it'll be really interesting because we're going to get them right after the bulk of the pandemic is over. It's been difficult to get into schools, as y'all might imagine, with the pandemic. But thank you very much. And we might
Thank you, Dr. Hoelscher. This was really interesting data and interesting information. And if you want to learn more about the survey, the link is in the chat box. But we do have one question, and I'm going to read it to you. It's in the chat box. I don't know if you can see it, but it is coming from Adrian Duran, and they're curious about the impact that the pandemic has had on the level of obesity. And they say that while children were faced with indoor confinement for extended periods of time, border kids seem to already have been behind, obviously by the data you just shown, in terms of healthy eating habits and the percentage of children that are either at overweight or obesity levels. So what are you expecting, or is there any way to know, or what are your thoughts on what you're going to see moving forward?
Well, actually, I just turned in a grant today that would follow the schools for a few more years to see kind of how this plays out. But the hypothesis in that grant is we think that obesity levels will go up and that diet will actually get a little worse. So part of the rationale behind that, there's something called a structured day hypothesis. And so a lot of times people say that school is bad for kids, but if you look at the data, kids gain weight during the summer. They don't gain it during school. And so it's very structured. You've got adult supervision, parents even are making kids have regular bedtimes. And in the summer, that kind of falls off. And then you see kids gain weight. So that structure is actually good. And so not having that for a few years, because even if they're in school now, it's a little bit more lax than what it was previously. So we're expecting to see the data go in a more negative direction.
Well, and that's unfortunate, but that gives us, all of us that work in these areas, really the impetus to really start to address it and figure out how to turn those trends around.
And you have, because it changed from 2000 to 2004, so it can be achieved.
Exactly, and that's good to know. That's great to know. Dr. Hoelscher, thank you so much for joining us today, and thank you so much for all your information. As a reminder, the information on the survey is in the chat box, so you can have a link to that. And also the bio for Dr. Hoelscher and all of the presenters today is in the chat box, and I encourage you to just learn more about these incredible speakers that we have today. So thank you again for joining us.
Thank you. Take care.
So we're really excited to move on to our next panel. And I want to introduce the panel members. And we're happy that it's going to be moderated by our own Sharmily Roy, who is the Director of Center for Social Measurement and Evaluation at Children in Risk. And the panel is on the pediatric health profile, and we have Dr. Carmen Rocco, who's a general practice physician in Brownsville, Texas. And then we also have Dr. Lisa Ayoub-Rodriguez, who is the Associate Professor, Texas Tech Health Sciences Center, right here in El Paso. So we're very, very happy to welcome both of them. And I am going to turn this over to Sharmily to start this panel. But again, I just want to remind everybody to encourage you to look into the bios of these incredible speakers. So thank you, and welcome panelists. And Sharmily, I'm turning it over to you.
Thank you, Deb. Those were some sobering stats shared by Dr. Hoelscher, so I appreciate her time. We're very excited to have a conversation with two pediatricians working in different parts of the state who will share a little about their work and the communities where they serve. So thank you, Dr. Rocco and Dr. Ayoub-Rodriguez, for your time with us. So I'm just going to jump into some questions for both of you. So Dr. Rocco, if you can go first, and then Dr. Rodriguez following. Can each of you tell us a little about the clinic and the setting where you work, and a little bit about the child patient that comes through in your clinic?
Absolutely. Thank you so much for having me. Buenos dias to everyone. And definitely so glad to be part of a conference entitled Children at Risk that basically defines most children or along the border. So it's good to be part of a conference that has that understanding. I was blessed. I came straight to Brownsville after I finished residency and went into a community and migrant center and spent about 12 years there. So it was an eye-opening experience to come out of a residency program and go straight into a setting where I could really see tremendous need in the community here. They were largely in the community and migrant setting. Of course, there were largely children that had limited access to the healthcare system. And there were children usually with multiple chronic medical conditions. That was more the average than not. After my 12 years at the Community and Migrant Center, I chose to go into private practice, primarily because the setting in the community and migrant clinics were changing in that the federal funding was requiring community migrant centers to come up with about 50% of the funding. So the community and migrant clinics had to change dramatically, and were basically attracting more a population that was insured. So I felt like I had more control over who we could see and how we could adjust their bill if I was in private practice. And that's where I have been for the last 24 years. The population overall has remained very similar over those years. And I think we're going to address that a little bit more later. But there's still a tremendous need to see children that have limited access into the healthcare system and that have lots of chronic medical conditions, what I call the medically fragile patient population in this area. And so that has remained at the core of our practice. Of course, in the last, particularly the last 4 to 6 years, we have seen part of the humanitarian influx of migrants into the area all along the border, particularly in the upper area. And so, yeah, that has been a challenge to try to get those individuals into the healthcare system.
Thank you. I mean, it's a very rich experience. So, Dr. Rodriguez, Ayoub-Rodriguez.
Thank you so much for the opportunity. I'm happy to be here today, and it's such an honor to be sharing the panel with Dr. Rocco. Sounds like she's dedicated so much of her career to such wonderful work. I am a pediatric hospitalist in El Paso, Texas, my hometown. I think a lot of the participants are in El Paso, so it may not need to be said, but El Paso, as you know, is abutting the border. I'm looking out my window right now and I can see Juarez. So that has colored my practice for the last 10 years here in El Paso. We have the opportunity to take care of a lot of acute care needs in the hospital that are colored by our border population. And there's a lot of different border populations. I have categorized them in like 4 different boxes. One box is the patient who lives in the United States, functions in the United States, but may not have an immigration status or access to medical care readily. Another one may be a United States citizen who lives binationally and their care is divided on both sides of the border, and their family and their everyday, their weekends and their school and everything is divided by an international border, which to them is seamless, but to our healthcare profession can mean a lot for their care implications. As Dr. Rocco started mentioning the humanitarian surges that we've seen, we've had the privilege to be on the front line of a lot of those transitions throughout the last half of a decade in my career. And we've seen how those evolved with each different change in political policy, the type of patients, the resources have all evolved. So that other patient population we see are family units. Family units may be admitted to the hospital. The children, I take care of them. They may either be in government custody, so they may be in the custody of Border Patrol, or they may have been released from Border Patrol and in this transitional status where they don't have that federal custody at that moment. So we have the family units. We have another classification of patients, which are the unaccompanied children. And those are often in either the custody of Border Patrol or in the custody of the Office of Refugee and Resettlement. And each of those patient categories have very unique needs. And also it takes the physician a little bit of intentional thinking to think through these patient populations and how does that affect the care that will be delivered and the follow-up that is needed. So yeah, I've had an awesome opportunity working in the front lines of the hospital, enjoying taking care of this very unique patient population that you can really only see on the border and provides this unique challenges.
Thank you so much. And I think it's just like, as you're saying, you know, the hospital setting or the community clinic setting, and also, you know, both of you are in very different parts of the state. Still, like some of the trends are similar, because I was seeing Dr. Rocco nodding her head yes to a lot of the things you were also saying, as that was you're describing the different segments that come through. So Dr. Rocco, I'm going to pivot this question towards you, because you've been in practice in Brownsville for such a long time and probably seen a lot of changes in the community, probably served, I'm assuming, multi-generation. Maybe you've had patients that are now have children that are now your patients. So I'm just assuming that. But I'm just wondering, are there differences in the children who you saw regularly maybe 20 years ago and who have come to the clinic now?
Well, in many ways, yeah, the two box idea that we had, I think, conceptualized is also for this question. In many ways, a lot of things have changed, in a lot of ways have stayed the same. We are still, as you heard Commissioner Stout say initially, we're still one of the poorest areas in the country. I think McAllen, the poorest, and we're second poorest. We're still largely undereducated, you know, about 24% actually high school graduation. And then there's an array of those that get up into the 9th to 12th grade. Of course, we are double the uninsured rate. So all of those statistics that you heard earlier have remained the same throughout my 36 years of practice here, which has really made practicing medicine a particular challenge. The health issues have, the obesity issue, as you just heard, has worsened. The issues related to obesity, the type 2 diabetes, for the first, you know, as we have evolved over the last several decades, we have seen the incidence of type 2 diabetes increase in children, where it's now just a common practice in pediatrics to take care of type 2 diabetics. Of course, COVID decimated our families. We have many families who have had one or more members who died, and children that were displaced as a result of that, either primary caretakers who were grandparents or parents, and that has gone largely unaddressed. We're just dealing with the Band-Aids that you have to deal with. Access to care throughout the 3 decades that I've practiced has remained largely unchanged. At the beginning, I think the politics of Texas was markedly different. And now, because we're one of 12 states that have not done Medicaid expansion, we have seen that that has limited the access to care, particularly along the border areas, where Texas, as you know, is the worst uninsured state in the country. Well, the border has double the number of uninsured population in the state. If Texas is 18, we're always in the 30s. And that's uninsured and then there's a huge number of underinsured. What has changed, if I have to put my finger on the one thing that has changed, particularly in the lower valley, it's the industry or the resources in some ways has changed. When I first came here, we were in the middle of NAFTA and the maquila industry, and it was industry that was really impacting health in so many ways. What we see now is an influx, as you know, Brownsville has a SpaceX, and so there's an influx of a different type of industry. We haven't seen that make an impact in health yet, or access to health, or a hospital access. For the first time in my career, we will have a children's hospital, a full service children's hospital. We've had a children's hospital in Edinburgh, but not a full service. So that's incredible that for the population our size, we are just now accessing that. So long-winded answer to your question, I'm sorry.
No, it's great because you have such a rich experience to be able to share that historical perspective. And this is actually great in terms of the infrastructure, as you were saying, you know, that there is more investment coming in. Possibly, if changes industry means like higher level, higher skilled jobs, that trickles down or comes into the community having, you know, some of the resources built, roads, better access issues that come into social determinants. So looking, you know, thinking positively about these changes in your community. And wanted to just like give Dr. Ayoub-Rodriguez a chance at this question. Have there been changes that you've seen from the hospital setting in the last few years?
Yeah, definitely. And I think I kind of alluded to it a little bit in my first comment. It's really interesting over the last few years what patients you will see in the acute care setting. So initially, rewind about 5 years ago, we saw a lot of family units who were out in the hospitality centers. So they were identified later as sick and then came into the hospital brought in by volunteers, by the network in the community that has provided the care to try to transition our families to their host cities after that. So that was about 4 or 5 years ago. And that was often a lot more acute needs that took a while to identify. Lots of late identified dehydration, kids who were just you could tell had been sick for a bit and quite a while. Now we are actually seeing a lot more kids in Border Patrol custody being identified and brought to the hospital. So as processes have changed and screening processes have been implemented, we'll often see Border Patrol bring children to the hospital to care for them. And then also as more unaccompanied children are in the ORR shelters and that network has been established and developed, you'll see a lot more kids from the ORR shelters here, and communication has become more established, which I think I'll talk about in later questions. But yeah, I think as policies have evolved, as things have changed, our patient population also changes, and it could be very acutely, actually, from 1 month to another. So that is really the unique thing about being on the front door. I mean, you know, several months ago, we had half a dozen to a dozen Afghan refugees within our hospitals. We have a lot of Haitian refugees right now. So really it changes as the climate changes. We're ready for Ukrainian refugees. If needed, we are ready.
As we had kind of alluded earlier on, you know, like in the region, you kind of are also kind of thinking internationally, you know, in terms of whatever's happening policy-wise, national policies kind of affect what's happening at your hospital setting as well, and in the community.
I will add that if I could for a minute, I totally agree. The networking within the community to assist with the migrant population has been good, what has been difficult is, for example, we will get newborn babies that are literally going to get on a plane and go somewhere in the United States with very little follow-up, not knowing what their access to healthcare will be in other areas of the country. So that's, and they have no choice because they're given a plane ticket to fly out tomorrow. So that's been a very difficult thing. The transitory nature of the humanitarian migrants that come through has been very difficult.
You're almost alluding to better health record systems, you know, like in terms of even like you were saying, binational people coming in with previous histories that now you have to extract somehow that are maybe from recall rather than transfer records. So those types of things in terms of maybe not even within the US having better records sharing and communication, but then even internationally, that being a challenge. And then on top of that, I mean, I was just thinking in terms of just measurements, you know, are you measuring weight in pounds or kilograms? And now you're having to do this math. I don't know if you're, do you have some kind of automation in terms of those types of things? But I'm sure part of it is also translating not language, culture, but also measurements and all these other things that you guys all have to keep in mind and be able to work with as part of your jobs every day.
I think they're in a survival mode. So the babies, if they don't have the ability to access the system, they're not going to have the resources. So you don't know what's going to happen. If there was national Medicaid, for example, which I guess we can talk about later, then that would be very reassuring. But that's not what we have. And so you don't know what's going to happen.
I think you hit it on the head with medical records and the importance of access to information to care for our patients. I can think of several patients I've taken care of in the last month that has been a huge limitation. We had one teenage male who had chronic kidney disease, and he was a great historian for being a teenage male all by himself in the United States for the first time. But what he could say is, in my home country, I got tests every month and I got a treatment every month for my kidneys, and they haven't been working my whole life. So we meet him and his kidneys are not functioning. He needs dialysis today. And as we keep him in the hospital, we realize like he not only needed dialysis today, but his kidneys continue to not function. So he needs it in 2 days, and then he needs it again on a regular scheduled basis. So not having any access to that medical record was very challenging. You had to start from scratch. And just like Dr. Rocco said, the population here they're not staying here forever. So if we get a biopsy, that takes weeks to come back to figure out the next plan of care. So yeah, we actually involved the Office of Refugee Resettlement in Washington, and they helped to transition him to his home city and ensure that he had a dialysis chair where he was going. And it was very multifactorial, trying to make sure that this kiddo got exactly what he needed and that transition of care. But and we did our best as an El Paso hospital to provide all the medical records that we obtained during that stay to provide them to California where he was going. And but the transfer of information is huge, and the lack of it and the opportunities surrounding that.
Thanks. I think this brings into question or like just another nuances of how people come through, like if they come in as a refugee status or asylum status versus some other ways, and what the difference in resources could be available to people as well as terms of that. You know, obviously for children, they all have right to human rights, and it shouldn't matter, but those things do end up coloring what you have access to. So the next question I would like to direct towards you, Dr. Ayoub-Rodriguez. I think you've already kind of going there in terms of some of the policies that you're thinking about, but I was going to directly ask you what resources or policies do you think should be implemented to prevent more pediatric patients being admitted to hospitals as your patients?
Yeah, I think prevention is a challenge because there's so many wide variety of reasons why our patient population come to us. And I think sometimes there won't be a lot of that prevention, but if we can identify the need for medical care early and make sure that we're intervening as soon as that need either arises or is identified is critical. So a lot of screening at every touch point, and then ensuring that that transfer of information is priority. So one, identification, two, ensuring that transfer of information is there, and then access to care. So the patient I described earlier with dialysis, thankfully we had an abundance of resources to provide him with the care that he needs. Let's change his status. So let's say he was a Haitian refugee with his mom in the hospital. So they come to us in Border Patrol custody. Border Patrol will probably process him while he's in the hospital, and then they will leave. And now his funding status no longer exists. And his follow-up and the resources to help to ensure follow-up no longer exist. So really it's making sure that all people have access to follow-up, access to care that they need, regardless of who happens to be sitting outside the door or which institution they're attached to. Everybody needs, if you need dialysis to survive, you need access to dialysis. So it's really ensuring that adequate follow-up in those next steps.
Dr. Rocco, do you have something to add in terms of at the community setting, maybe some more freedoms that you have, but in providing access to care, but in what would be, some policies and resources that you think are needed?
Yeah, I couldn't agree with what Dr. Rodriguez just said. Identification and making it, the process right now is so cumbersome. I know that they've extended it to a year, but over the last four to 6 years, our families have become really afraid to go get recertified for Medicaid and other healthcare services for fear that the undocumented would be deported, as some of them have been. So making all of that easier will definitely help to reduce the lapses that we're seeing in healthcare access. And that's so important. The other thing, of course, the obvious, the elephant in the room, the Medicaid expansion. It's so important because the uninsured population, even among children, and especially among adolescents, is really so hard. Definitely, we struggle every day to try to figure out what in the world we're going to do to help children that really, really need access to care. The other thing that has really changed significantly is the school nursing program in communities like the ones that Dr. Rodriguez and I practice in. We would use the school nursing programs in these communities to do a lot of healthcare, and the nurses would the school nurses would help us a lot with helping us access resources for children that were underinsured or uninsured, and that the funding to that has really been reduced. And I also love the promotora programs in these communities. That's something that has made such a significant impact in communities where it's so difficult to get to parents. We utilize at least 1 or 2 staff members just to be able to find families that we need to find because of critical healthcare issues. And then lastly, I can't emphasize what Commissioner Stout said at the beginning, primary care and subspecialty. It's hard to recruit people to come to these areas, even, and I know it'll take time. We haven't had a medical school here for very, very long. I think it's 5 years or so. So we haven't seen the true impact, but very difficult to recruit primary care doctors and subspecialty care. Our families have to go very far away sometimes to access that. And I can go on and on if you want me to.
I think we were kind of coming up to a close in time, and you have such a rich experiences, and I'm sure we could have just had, you know, a couple of panels on this, kind of going further into each of the areas that you guys have even touched on for just a, you know, a few seconds. But yeah, I just wanted to ask each of you if you have any last minute thoughts in terms of anything that we didn't ask you that you'd like to highlight and talk about, because I know you were just talking about the medically underserved area and what can be done to recruit more, if that's something, but other things that you're thinking of.
I wish I knew more about the participants. I know you gave me a little bit of an idea of who we're speaking to, but certainly encouraging young people to come do internships in these areas so that they can experience. I know that you know, if you can't do international health, you can certainly do border health. So if you can't convince your universities and other areas to send you outside of the United States, the border health experience will give you everything you probably would experience in an international setting, because it's so different, and you're never going to get bored in healthcare if you practice along the border.
I absolutely agree. I think practicing on the border is really a unique experience and a unique practice of medicine that a lot of people don't realize until you're here. It's so gratifying. The patient population is very appreciative. You really have a chance to make a difference and feel like you can leave a lasting change. So it truly has been a pleasure working in this setting and helping this population. And yeah, definitely we need to continue to grow our healthcare workforce and continue to provide education to our healthcare providers about the aspects of care that are different and that take a little bit of special attention. We're so used to taking care of the pneumonia, but thinking beyond that and trying to address all of the needs, the social determinants of health of the border.
Thank you both for such a rich conversation and just kind of sharing this, you know, varied experiences. I'm going to hand it over back to you, Deb.
Thank you, Sharmily. And of course, our thanks to Dr. Rocco and to our own El Paso, Dr. Lisa Ayoub-Rodriguez, for all their great work. It was interesting in the chat box. Obviously, a huge amount of thanks to each of you for what you do in your community. But there was also a comment made that so much what you all talked about was so similar. If we didn't know which community it was, we would have thought it was the same community. I'm sure if we talked to physicians and healthcare workers, especially those that work with children all up and down the border, we would see so many commonalities. So it's just so interesting to hear about all the work that you're doing, and we thank you for what you do in your communities. So I'm really excited to introduce our next speaker, excuse me, Ruth Mason. And one of the things I think we've listened to our first two sets of speakers, our first two panels, we've talked a lot about, you know, nutrition and about care for children. And I guess, you know, we would not be, any of us would be surprised that we're going to also talk about the effects of poor nutrition and childhood diabetes. And we're very, very happy to have Ruth Mason here. Again, her bio is in the chat box. A link to it is in the chat box. So, and we just welcome you and thank you for joining us. And I'm really looking forward to hearing your presentation. So with that, Ruth Mason.
Thank you. Thank you for allowing me to be a participant in this important event that will hopefully allow us to make an impact. And sorry, I just lost my notes. that will hopefully allow us to make an impact and promote change. Our focus on children and providing them support and resources to allow them to have a healthy lifestyle and grow up to become healthy adults. It's heartwarming. It's really impactful that we're getting together today and doing this. I've dedicated 18 years to the neonatal population and have seen firsthand how our interventions have lifelong impact. So it's an honor to talk about childhood diabetes and how our focus should be shifted. Next slide, please. If we're going to talk about barriers and challenges faced with childhood diabetes, childhood diseases and find solutions, then we need to start from the beginning with preventative measures such as proper prenatal care and education. Census 2021 reflects that there are 430,000 children residing in the Rio Grande Valley, which includes Cameron, Hidalgo, Willacy, and Stark County, with a vast majority residing in Cameron and Hidalgo County. In addition, the poverty rate is twice as high compared to statewide, with a median income of $35,745 and the highest proportion of uninsured women of reproductive ages, with a 36.6% along the Texas-Mexico border. The CDC reported a 4.8 increase per year for type 2 diabetes and 1.9% for type 1 during 2002 and 2015 for youths younger than 20 years. 20% of children were between the ages of 6 to 11, and 21% of adolescents between 12 and 19 that suffer from diabetes and, from obesity. This is for the entire US population. Education should be focused on the benefits of breastfeeding and addressed in the perinatal period. Next slide. Education should be focused on the benefits of breastfeeding and addressed in the perinatal period. This needs to be a collaborative effort between the OB-GYN offices and the hospitals. The education and assessment on where the patient stands should be established in the OB office. It's challenging once they come to the hospital to make a decision while they're in the hospital, as the patient is experiencing numerous emotions and a high level of stress, which creates a barrier to absorb and understand the education provided. I'm a firm believer that they will be more successful with breastfeeding when they come prepared with a plan and when they come to deliver their baby. So we know that breastfeeding is simple and natural and provides the proper balance of nutrients baby needs and is recommended for the first 6 months of the baby's life. Breastfed babies not only have a higher level of thinking, but also have a decrease in incidence of diabetes, both type 1 and type 2, as well as lower risk of becoming overweight and obese later in life, and a decreased incidence in childhood diseases. Hospitals need more funding to provide birthing and breastfeeding classes and to serve the changing population. You can't use the same approach to teach parents on breastfeeding that you used 10 or 20 years ago. We need to change that. It's even if the message and the goal hasn't changed, we still have to be more creative and be one step ahead of the parent and the patient. Then we have COVID, which increased the fear of mothers on exposing their infant while breastfeeding. Dealing with these fears felt like starting over due to having to provide reassurance, support, and education. It felt like taking 2 steps back on the progress we had already established with breastfeeding. Next slide, please. What we expose our children to will impact them throughout their life. Teaching healthy habits at a young age, such as diet, weight management, and the importance of exercise routine is crucial for every child development. It's important to note that an overweight child at 6 years of age has a 25% chance of being overweight as an adult. If parents teach their children healthy habits, they will carry that with them and make wise choices as they grow and as they become adults. Next slide, please. As parents, it is our responsibility to make those choices that will keep our child healthy when they are too young to make those choices. Among the healthy options include measuring and monitoring serving sizes and snack replacements, avoiding certain foods such as deep fried foods and fast food restaurants, as well as daily physical activity that will help build strong bones, improve motor skills, burn excess calories, and help with following directions. Next slide. We know that it is challenging to give our children healthy food when nutritious and organic foods are more highly priced than non-nutritious foods. So that's something that we really need to look at. Studies show that 30% of children lack consistent access to a healthy diet, resulting in a delay in physical, intellectual, and emotional growth. Children spend 6 to 7 hours in school also, resulting in consumption of at least half of their daily intake at school. Studies show 30% of children lack consistent access to a healthy diet, resulting in, oh, I'm sorry, I already said that. The CDC recommends actions to improve nutrition in schools, such as ensuring all foods and drinks outside of the school meal program are nutritious, offer non-food items such as rewards, and provide more access to drinking water. I have a 10 and a 13-year-old, and I see the challenge with access to drinking water due to COVID. I have to make sure that my children take a water bottle and fill it at school, or they take bottled water on a daily basis. And it's been really challenging for them. You're not sure what they're drinking anymore at school. Next slide, please. Perhaps fun, interactive, and physical activity classes should be offered by local gymnasiums and trainers with grants awarded to facilities and support such programs. The service for the community will help influence healthy habits and help keep children healthy. An increase in type 2 diabetes in younger individuals has been linked to overweight children, resulting in illness and issues with kidneys and eyes of those individuals who experience diabetes at a young age. A sedentary lifestyle can magnify the risk for obesity. We have to set limits and provide guidance to avoid sedentary lifestyle. Parents need to be creative and invest time, effort, and money to provide opportunities for physical activity while confined to our home through virtual reality games and other video games or online membership classes, but not everyone has the financial means to provide these resources for their children, especially in the Rio Grande Valley. Not everyone has internet access or, as mentioned earlier, financial means. So we have to be creative. Next slide, please. In order to bridge the gap, we need to shift the focus on funding for education, decrease unemployment, poverty, and support low-cost childcare for parents to be able to receive a higher level of training. And of course, funding for the improvement of living conditions, especially in colonias, which will eliminate disease rates and health issues. Our issue is nutrition and parent education. Most of the data is focused on adults with very limited data on children and preventative measures that will make a lifelong impact to our community. Finally, access to affordable health insurance to ensure preventative measures are taken to improve the life of the child at risk and decrease those factors. Next slide. Thank you.
Thank you. Thank you so much for all that information. If you could share with us one thing, let us look into the crystal ball. And I know, again, there's lots of various factors, a lot of things, but what would be the one thing that you would, what message of inspiration moving forward would you give us?
I would say we need to focus on our breastfeeding. That's our big factor that CMS has a goal for us as a hospital, 50% of breastfeeding, exclusively breastfeeding. We're meeting challenges, I think mostly on the border towns. I think it's mostly due to our customs, our traditions, as most of the Hispanic population, as you saw on my demographic slide, there was 94% of Hispanics in Hidalgo and Cameron County each. So I think just the teaching education of moms to understand that breastfeeding affects lifelong, it can mold the child and help lifelong, make lifelong health wellness. So I think breastfeeding should be our focus. Teach moms. We have a lot of needs for a lot of funding need for education to provide opportunities for more breastfeeding education in the hospital and outside in the community. We do our little breastfeeding fairs, but we don't get a lot of participation. And we also have the older population that basically advise mom who's sometimes a teenage mom, or it's just a mom that's not educated with no financial means, and the grandmother or the mother will advise that they give formula. So that's our challenge right there.
Well, thank you so much. That's really great. That's good information for us. So thank you. And we're so excited to introduce our next panel. And it is on, let me get my little notes up here. So, excuse me. The next panel is going to also be moderated by Sharmily Roy. We've introduced her previously, and it is going to be on strengthening community health capacity. And I think this one is really going to be a good opportunity for those of us to really figure out, again, building on what Ruth Mason said, Ms. Mason said, how do we move forward and begin to increase the capacity of our communities after the pandemic? So our speakers are Denise Vasquez, who is the research coordinator at UTHealth, and Hansel, Ibarra, who is the program director at MHP Salud. And with that, I'm going to turn it back over to Sharmily. Thank you all for joining us this morning.
Thank you, Deb. I wish we could give you a round of, applause for you to keep us going. I want to thank both of our next speakers in understanding the importance and the role of community health workers and promotoras in addressing various social determinants of health and supporting health capacity by sharing a few examples from their work in the communities that they're working in a couple of different places. Again, one of them is in the Rio Grande Valley area, and one of them is in El Paso and surrounding area. So just wanted to give a couple of different profiles of what that looks like. So I want to thank Hansel Ibarra for opening the session, and we will have Denise following right after.
All right. Well, good morning, everyone. I'm honored to be here. My name is Hansel Ibarra. I'm a program director at MHP Salud. And today we're going to be talking about building capacity, building community health capacity. Next slide, please. Thank you. So before we get started, a little bit about us, about who MHP Salud is. We are a nonprofit organization that promotes the community health worker profession, also known as the CHW or Promotores de Salud, as a nationally culturally appropriate strategy to improve health programs and empower underserved Latino communities. As an organization, we value community-driven approaches based on collaboration, empowerment, and proactive problem solving to eliminate the root cause of health inequity. And we basically are made up of two arms. Our first arm is our CHW-led programs, where we have over 35 years of experience of ourselves manning CHWs on the ground and offering our programs. These programs provide peer health education, increase access to health resources, and bring community members closer. Aside from that, we also have our training and technical assistance arm. And this is where we provide extensive training, and we have over 20 years of doing so, offering to health organizations assistance in the CHW training, specifically tailored to their needs. Next slide, please. So before we get moving on forward, a reliable solution to aid with increasing the community health capacity is the integration of a CHW. So what is a CHW? A CHW, or a community health worker, is a frontline public health worker who is a trusted member of his or her community and has an unusual close understanding of the community they serve. This trusting relationship enables a worker to serve as a liaison, a link, an intermediary between health and social services and the community to facilitate access and improve health, the quality and culture competence of the service delivery. We say trusted member of the community because most of the time CHWs are from the same community they serve, speaking the same language, sharing the same beliefs, or at least understanding those beliefs. So who can be a CHW? Anyone from the community who has an understanding of those views, beliefs, fears that the community might be having. So people such as your local priest, a teacher, a community leader, or active neighbors. What do you look for CHWs? Your community. They don't have to speak the same language, but at least have an understanding of their fears or their customs. When are CHWs useful? They are useful before, during, and after emergencies, whether these are natural or personal emergencies, health or non-health. Also when trying to implement new programs in communities. So why would you want to use CHWs? CHWs can act as a bridge between the health system and vulnerable communities they are trying to reach. CHWs are widely known to improve the health of their communities by linking their neighbors to healthcare and social services, educating their peers about disease and injury prevention, working to make health services more accessible, and by mobilizing their communities to create a positive change. Underserved communities that experience barriers to good health are often at greater risk of developing poor health and are more likely to reject or be unaware of available assistance. This can be due to the lack of health education, miseducation, social stigmas around health topics, lack of culturally appropriate material or support groups, and the gap between those in need and the available services. The community health worker works in addressing poor health the community healthcare worker's role in addressing poor health is to educate the community on healthy living, provide support to those who are suffering of poor health and their loved ones, and act as a bridge between affected individuals and available resources. Next slide, please. And they go ahead and do so through 3 different branches. They do so through education, through providing support, and by offering resources. Through the education, we have the building of capacity, disseminating information. We also have providing alternatives. They also assist with self-care, and they also increase your health literacy. When it comes to support, they do so in a clinical aspect, in a non-clinical aspect. And when it comes to offering resources, they can assist with things such as transportation, giving referrals, advocating for the community themselves, and also providing aid. Next slide, please. So MHP Salud has 2 programs that we offer in the community that we are leading. One of the first program is called Juntos Podemos, and this is a program that lasts 4 weeks, and it is led by our CSW, and it's a prevention program that targets healthy eating and physical activity among SNAP-eligible families with children between the ages of 2 to 13 years. Individuals who qualify for the program are identified through outreach conducted by the community health worker. The community health worker informed these individuals about the benefits of healthy nutrition and active lifestyles, and then invite them to participate in the program's health education classes. To ensure that the program services are accessible to all individuals who are either receiving or qualified for SNAP benefits, the classes are offered at multiple locations, whether it be at community centers, at schools, churches, parks, or similar locations. Juntos Podemos began in July 2017, and it is funded by the Texas Health and Human Services Commission and offers services in 4 counties, which is going to be Cameron County, Hidalgo County, Starr County, and Willacy County. Some of the outcomes for this program, we did notice that we had an increase in daily physical activity, vegetable consumption, and fruit consumption, and this was after they took a pre and post test. The other program that we also offer in our community is going to be our Connecting Kids to Care. This is in the Rio Grande Valley. More than 1 out of 5 children who are uninsured live in the USA, live in Texas. Predominantly Hispanic and Latino communities, known as the colonias of the Rio Grande Valley, have some of the highest child uninsured rates in Texas. This is due in part to the lack of public services, the ability to afford healthcare, and the fact that many of their parents' employers' health insurance plans don't cover the children. Additionally, many Hispanic and Latino families in the Rio Grande Valley are less likely to be aware of any programs available to help pay for insurance due to their social factors, such as availability of information or resources in Spanish. CSWs in our Connecting Kids to Care initiative provide bilingual information and application assistance for government programs such as Medicaid and CHIP to families with children, pregnant women, and the elderly with certain incomes and people with disabilities. Our CSWs are also trained to help families figure out if they qualify and provide guidance on the documents that are needed for the application process. Those who qualify receive benefits such as coverage for doctor visits, dentist visits, drug prescription, vaccines, eye exams, hospital care, and more. Connecting Kids coverage provides application assistance for children and their caregivers, specifically for CHIP and Medicaid. Next slide, please. And this is a little description of what the area that we cover. If you see there in Texas, we go ahead and cover those 4 counties, which is going to be your Willacy, Starr County, Hidalgo County, and Cameron County. I wanted also to show you some information. This graphics that I have here are in regards to obesity and diabetes are from 2018, so they're a little bit old, but it does show that about 40% that there's fewer primary care physicians per 100,000 compared to the rest of Texas. So it just shows you that this area is predominantly Hispanic, and we see that there is a lot of lack of medical services in this area. Next slide, please. So some characteristics of the communities of the people that we went ahead and provide services. So for Juntos Podemos, we noticed that the household income, about 85% of those individuals earn less than $25,000. About 14% earn a little bit more than that. So that shows you that the majority of individuals that we're assisting do fall below poverty levels. The highest education levels for their parents, we had the majority of them not completing a high school education or getting that GED. We had 26% of them having completed high school education and obtaining that GED. The average age of the individuals that participated with us on Juntos Podemos was about 29 years. And we have predominantly Hispanics with 99%. For connecting kids with care, the household income also, we see that the majority of the individuals are earning less than $25,000 a year. The majority of the individuals also lack high school education. This individuals for this program, where the majority of them were 39 years old, and where they were predominantly also Hispanic. Next slide, please. So some of the general characteristics of the communities that we are serving they are full of stigmas and miseducation. So some of you guys might be aware of familismo, where you basically put others ahead of yourselves. This is something that we experience here in this community. It is hard for the individuals to go out and look for help because they would rather put their families ahead of themselves. They would rather go to work than miss a day of work because they're maybe the head of the household. There also is a lot of fatalismo in this area. This is going to be the individuals basically leave it up to, they think it's destiny. They say, hey, you know what, if it is what it is. If I get sick, I get sick. There is no need for me to go out. Será lo que Dios quiera, which is sometimes what is said. And you also have the stigma that in order to be healthy, you have to be a little big. I remember when I was younger, I would go visit my grandma and she would tell me, mijo, you're looking a little sick, you need to get a little bigger. So those are things that we have to go ahead and combat. And those are some of the characteristics that are here in this community. There's also a lot of lack of infrastructure, things such as parks, transportation, public transportation, sidewalks, grocery stores, public lighting. You'd be surprised that a lot of this, some of these individuals also have outhouses. It is amazing that now in the 21st century, people still have to go outside their homes and basically do the businesses in an outhouse. There's also a lot of lack of representation. As we have mentioned, there isn't many physicians in this area, and the physicians that are in this area are predominantly either Caucasian or they're of a different ethnicity. We have about 5% of the physicians that are in this area see themselves as Hispanics. We also have the community has a lot of mixed immigration status families. So we'll have some individuals that are citizens, we'll have some individuals that are residents, and we'll also have some illegal or some illegal in the households as well. There's also predominantly living in colonias. So these individuals live in areas that are lacking sewers, that are lacking public infrastructure. If available, a lot of these individuals will cross over the border to get their medical services. We also have a lot of families living in multi-families. So it is very common to go into the community and find out that there's two, three, four families living in the same household. You do see that there's a lot of low levels of homelessness, and that is because of that, because there's a lot of multi-families, and families would rather invite others to come into their household than leave their own family members out in the community. So you do have low levels of homelessness in this area, but you do have a lot of multi-families living in per household. Next slide, please. Some general characteristics of the children. As I mentioned, more than 1 out of 5 children are uninsured in this area. The children in this area also have high chronic illnesses, and they also have high levels of obesity and overweight. Next slide, please. I wanted to go ahead and mention if individuals are interested in starting your own CHW program, or if you're thinking about doing so, MHP Salud can go ahead and do so. You can go ahead and reach out to our website, and we have guidelines as to what to do to go ahead and start a program. And if you already have started a program, what to do to go ahead and make it better, get it to that next level. Next slide, please. And that is it on my part.
Thank you so much, Hansel. This is really great in terms of the things you highlighted in terms of bilingual support, navigation for service providers, and then working with the whole family to work with the context of the culture and the way people work together. I want to hand the next, Denise, are you available? Just get it.
Yes.
Thank you.
Thank you, Sharmily, and thank you to Children at Risk for inviting us to be part of this conference. Today, I'll be presenting on a project we conducted last year as an example of how community health workers can help strengthen community health capacity. This project was focused on child home safety, preventing unintentional injuries to children in rural border homes. And before I begin, I just want to thank the Texas Department of State Health Services, the Office of Border Public Health, who funded and guided this project. And I also want to acknowledge my colleague, Yvonne Gaddy, who was the person who carried out this project from beginning to end, our PI, Dr. Lewis Brown, and the community health workers who implemented the project listed here, Sylvia, Lupita, Yadira, Dora, and Cecilia. Next slide, please. Okay, so as we all know, children are very curious, and as they grow up, they're going to fall and experience injuries. Unfortunately, some of these injuries can be more severe and life-threatening. According to the CDC, unintentional injuries are the leading cause of disability and death among children from 0 to 19 years old here in the US. Next slide. So here are some quick facts about unintentional child injuries. Approximately 9 million children are treated for injuries in emergency rooms every year. 225,000 require hospitalization, and the medical and societal costs for these injuries are about 87 billion per year. Most unintentional injuries happen at home and are preventable, and children in low-income rural areas are the most vulnerable to these types of injuries. Next slide, please. So the goals for this project were, 1, to create a CHW curriculum to raise awareness and knowledge on the prevention of unintentional injuries in Hispanic and border communities along the Texas-Mexico border. And 2, to evaluate the CHW curriculum by training CHWs to conduct home assessments, and then conducting home assessments among the target community. Next slide, please. So this is the target population for this particular project for the curriculum that was created. It's these rural counties along the border that you see here highlighted in green. These 32 counties have rural communities, and for our project, we worked here in El Paso and Hudspeth County. I should have highlighted them, but they're the farthest west counties that you see here in the tip of Texas. Next slide. So why focus on rural border areas? As some of the previous speakers already mentioned, some of the healthcare challenges that we experience along the border, but I would say that it's even more prominent among rural communities. We see high poverty rates, language and cultural barriers, limited access to healthcare services. This one is especially prominent. And then low wage jobs with no health insurance, no legal documentation, making it harder for families to have health insurance, and unable to pay for healthcare. Okay, so these challenges are more prominent, or make it more difficult for rural communities to address unintentional child injuries. They experience difficulty commuting to the nearest healthcare service. Also, the loss of income or jobs due to caring for an injured child is probably more difficult for the families. There tend to be more single mothers, and also a younger maternal age, which could make it harder for them to know what to do when a child is injured. Okay, so as Hansel already talked about, he already covered, what the community health worker profession is and why they are ideal for these types of community programs. But I would just like to say that, for this project, it was very important that the community health workers provide culturally competent and culturally sensitive education, because we were asking strangers to let us into their homes during the pandemic, and then to allow us to assess possible hazards that could be present in their home. So I think the community health workers really did a great job of explaining that in a sensitive manner to the participants, making sure they knew that we weren't there to judge them, that we weren't going to report them to anyone, that the focus of the project was to help them create a safer environment for their children and to give them a peace of mind that they were doing all that they could to prevent the most common injuries in the home. Okay, next slide. Thank you. So real quickly about the curriculum, it's a 5-hour course. It consists of these 3 modules that you see listed here, and it comes with a pre and post test. Next slide. These were the common home hazards that were covered in the curriculum. And on the right, you can see the resource guide that was provided to parents to help them, give them ideas or recommendations on how to mitigate the specific hazards that were present in their home. Next slide, please. And here's what we did to evaluate the home assessment. We worked with 47 families in 5 low-income Hispanic communities here in El Paso and Hudspeth counties. Data collection was done in 2 visits, 30 days apart last summer, and using a home safety checklist to identify hazards. The outcome measure was the reduction in proportion of homes with hazards from visit 1 to visit 2. And the analysis that was done were 2 sample tests of proportions. Next slide, please. This is just the checklist that the promotoras or the community health workers use. So they would go room to room and then go hazard by hazard, identifying if a specific hazard was present or not. And then they would do the same thing for visit 2. Next slide. Here are just some pictures of the project implementation. We gave them an incentive package and during visit 1 and another one during visit 2. And they each had some items and some safety devices to help them address the home hazards at home. Next slide. I'll go ahead and skip this slide for now. Thank you. And I'll move on to the home assessment results. So here are the results. You can see the proportion of homes with a hazard during visit 1 and then during visit 2. And we had several hazards that had significant reductions between visit 1 and visit 2. For example, electrical, 81% of homes had some kind of electrical hazard during visit 1, and this went down to 22% for visit 2. Another one, sleep hazards, items in the crib. There were about 1/3 of homes that had this hazard, and this was reduced to 1% by visit 2. Okay, next slide. These are just some examples of some of the most common safety devices that the families use, some of the devices that were provided. And finally, in conclusion, this is again just one example of how community health workers can help strengthen community health capacity. The findings suggest that CHW-led interventions effectively reduce home hazards for children in low-income, rural Hispanic border communities, that they are well suited to address feelings of distrust and influence, the acceptance of these types of programs, and that these programs are also a great opportunity to inform residents of other available resources, such as food pantries, low-cost clinics, and domestic violence shelters. And finally, child home safety educational programs can help reduce medical and hospitalization costs associated with unintentional home injuries. And that's it. My next slide has my information. And I thank you all for your time.
Thank you so much, Denise. Such important work in terms of health literacy and health education in terms of just informing people what they can do and just of that allowing people to take the actions that they need. A quick question for both of you, and I'm sorry, we did have to rush to this panel. There's so many layers to everything you're sharing. But just wanted to ask each of you, if you don't mind sharing a little about yourselves, can you tell us what brought you to your work, to this work, and how do you see, community health workers as being a solution to healthy communities? Hansel, if you can go first.
All right.
30 seconds.
Sure. So growing up, everything that I saw in my environment seemed normal. Lack of infrastructure, lack of sewers, lack of sidewalks. So to me, that was something normal. But as I kept on getting older, and I see, and I get more educated, I see how the valley is lacking in a lot of those things. And it is very difficult for you to expect someone to pull themselves by the bootstrap when there's a lot of factors that are going up against them. And I believe that that's where the CSW comes in. The CSW is someone from the community that is there to provide information to the community. And through information, you get educated, and education is power. So I believe that that is the best way to assist through providing education, giving that power to the community so they themselves can go ahead and providing them with the tools.
Thank you, Hansel. I'm sorry again to rush you. Denise, do you have a few thoughts on this?
Yeah, just similar to Hansel, I also grew up here on the border, and I saw families struggle a lot with the complex healthcare system that we have here. And so I think that made me want to go into public health and help, my community navigate as well. And as far as community health workers, they are the ideal communicators, advocates, connectors, because they are trained to provide health education, but they oftentimes have the same lived experience as some of as the population that we're trying to serve and to help. So they, they're unique in that way, that they have that special understanding of what it takes to engage them.
Thank you so much, and I appreciate your sharing and taking the time to share this with the audience here.
Thank you, Sharmily.
I hand it back to you.
Thank you, Sharmily, and of course, thank you to Hansel and to Denise. Wow, it's when you really hear the stories and the real work that's being done at the grassroots, it's just inspirational. So thank you for sharing your stories and your great work. So I'm really excited to introduce our next speaker, Dr. Leah Wiggum. And Dr. Wiggum is the Associate Professor at UTHealth and the Director of UTHealth Center for Community Health Impact right here in El Paso County. And again, I'm very, very proud of our partnership with Dr. Wiggum and the UTHealth department here in El Paso. So with that, I will turn it over to Dr. Wiggum.
Thank you so much, Deb. And I feel the same way. We've got so many great partners, and United Way of El Paso County is one of the partnerships we're so grateful for. I'm going to be talking a lot about partnerships today because what our team does at the Center for Community Health Impact is we help to implement a model called the Collective Impact Model that you can think of as kind of a super collaboration approach to address really complex problems in our region. And the complex problem kind of underlying all of the work we do is obesity. Obesity is a complex disease. It's not simply a matter of improving lifestyles, it's also addressing the root causes of the disease. And I'm going to talk today a little bit more about how we go about doing that using this model that has had a really great impact in our region. Next slide, please. So at the Center for Community Health Impact, or CCHI, our mission is to impact health through community-driven solutions that are informed by science. So I'm a scientist by training. Our team at UTHealth is made up of scientists, but at the core of what we do, everything is community driven. So our partnerships in our region are essential. We start there. We start with what our community partners are telling us are the biggest challenges that they're facing. And then we tap into our scientific community to help identify strategies and solutions that can address those barriers. And all of this is part of a vision to create an environment that supports healthy eating, active living, and overall metabolic health. Because as you all know, and as we've heard today, obesity is an underlying chronic disease that then impacts many downstream diseases and other aspects of health like diabetes, heart disease, hypertension, kidney disease. These are all problems that we face at very high levels along the border. And so being able to address obesity and related environmental factors that can contribute to obesity is really important. Next slide, please. So just briefly to explain to you what the collective impact model is, and the next slide will actually have a reference that you can make note of if you want to read more about it. But for collective impact to work, you need 5 components: a common agenda, a shared measurement system, mutually reinforcing activities, continuous communication, and a backbone organization. I should note that backbone organization can actually be made up of multiple organizations partnering together to drive that common agenda. Next slide, please. So the way our team has been working to use collective impact in this region, we're really fortunate because there was a vision through one of our key local partners, the Paso del Norte Health Foundation, more than a decade ago, to establish backbone organizations to address some of these complex problems in our region. And so we were fortunate to have funding from the Paso del Norte Health Foundation to get this work started about a decade ago. We use the collective impact model to ensure that projects align with the needs of the region and unite the work of partners for the purpose of solving these complex problems. So this idea of a common agenda is really essential because it brings partners together to ensure that there's alignment, so that when there's multiple entities working towards addressing, common problems or challenges, that work works collectively to drive impact rather than in silos. And I'm going to give some examples in a moment about a common agenda related to food systems and how that developed. The shared measurement system really strengthens these efforts, because if you use a shared measurement system to measure the markers of impact or success that have been laid out in your common agenda, then you can really identify what's working well and what's not. And that lets you then lead to better decision-making and better strategic planning, so that you've identified where the strategies are working well because you have this shared measurement system that you're applying across multiple efforts. And then you can shift strategies or redesign approaches to ensure you're driving better impact. So all the boots on the ground efforts that are happening to drive towards some common agenda, let's say increasing fruit and vegetable intake as an important central part of healthy nutrition and healthy diet. If you use a common measurement, such as our reflectance spectroscopy technology, which we call the veggie meter, you can see there's a little girl there in the center bottom of the slide who's having her veggie meter score assessed. Then that lets us understand which programs are working well to drive change in fruit and vegetable intake, which ones aren't working so well. That way we can shift the approach where it's not working well to get better impact, and we can optimize resources that are going into the strategies that are working well. So all of that feeds into the continuous communicating with these partners, making decisions collectively, ensuring that these mutually reinforcing activities, like how we produce our food in the region, how we distribute it to ensure that it's getting to people, and making sure that the programs used to drive the behavior change to increase the intake in this particular example are working well. So that's kind of a big snapshot of how collective impact works. Next slide, please. We have several different partnership areas that we work in, and you can think of collective impact within each of these partnership areas, and sometimes that collective impact crosses between partnership areas. And so what I'm going to do today is just highlight some examples of how we've applied collective impact in a few of these areas. I won't have time to go into all of them in great detail. And for example, the built environment example, I'm not going to talk about it all, because one of our speakers coming up, Dr. Juan Aguilera, he's going to be talking about some of the work we've done in the built environment area. So I decided to save time there. Next slide, please. But if we think in terms of healthy schools, we have used an approach here where there were some individual efforts happening where our team was supporting program development and evaluation using that shared measurement system I talked about. And we, along with our partners at the Paso del Norte Health Foundation, when we talked about this, we could see that there was really a need to build a coalition here. And so coalition building became kind of our primary focus, while maintaining the program development and evaluation at different levels of school districts and different campuses. We also worked with Paso del Norte Health Foundation to come up with a strategy to develop a coalition. And to do this, we pulled in a new partnership with Action for Healthy Kids. And we have speakers from Action for Healthy Kids and the Paso del Norte Health Foundation coming up next, so I won't talk a lot about this. But this coalition served the purpose of providing training where needed, both within districts and to partners outside of districts who had an interest in school health, assessment using tools such as the WellSat and the School Health Index, the SHE, to really understand what's happening. WellSat does kind of a district level policy assessment. SHE is used at the campus level. And then that assessment helps us make decisions as a coalition about how we want to drive things forward. And then advocacy, training around advocacy, support for advocacy, because sometimes in our school district work, we've seen that we've got great actors within the districts that are passionate about health and doing all the right things, but they need help from people outside of districts to kind of raise awareness among district leaders, superintendents, school board members, and so forth, as well as city and county leaders to help kind of align those efforts and make sure those within districts making some of those decisions really hear the voices of the parents and the other community members about where the priorities need to focus with regards to health within schools. Next slide, please. Food systems is another partnership area that we've done a lot of work with. This particular effort started about 8 years ago with a large assessment effort where we brought in some national experts in this area, an organization called the Food Trust, who helped us with an assessment project that looked at, it was kind of a multi-component assessment where we did key stakeholder interviews with about 30 stakeholders. We did surveys of community members, especially those living in parts of the region that were most affected by food access. And we did a series of maps that helped us identify. The map you see in the front there is the composite map that really highlights key areas of need based on low income level, low grocery store sales, and high death due to diet related diseases. So by overlapping those kinds of data in a geospatial way, we were able to pinpoint parts of, in this case, you can see we're focused in on El Paso County where the highest needs were. Then what we did was we held a summit. You can see a picture of that summit here on the slide, where we engaged key stakeholders from the community so that we could show them the data we had collected from the interviews, the surveys, and the mapping, and present to them best practice from other parts of the country, practices that had helped to really drive increased access of healthy and affordable food. And both of those are really essential along the border. We want healthy food, but it also has to be affordable, of course. And then we engaged those stakeholders during that summit in a discussion based on the data, based on what we know from best practices in other places, what will work for our community. And that summit ended with kind of 3 main priority areas that then our team has ensured that we keep focused on those priority areas and how to move forward in those areas. The summit also served the purpose of driving buy-in from key stakeholders. So several coalitions and task forces were formed from that summit. The report that you see in the top right corner, the Food for Every Child report, summarized what came out of that summit. And then these coalitions and partnerships started to work towards the solutions to the priority areas that were identified from that process. They've led to things like establishment of a healthy food financing initiative, which was possible because of great leadership within our county. Commissioner Stout, who you all heard at the beginning of this webinar, was an essential leader in that effort. And we really appreciate the partnership from the County of El Paso Department of Economic Development and the county commissioners who have supported this effort along the way. Healthy Food Financing Initiative is an economic development strategy that focuses on healthy food retail and the infrastructure to support it. We've also done work to address the SNAP gap, as it's called. So this is the fact that El Paso County leaves millions of dollars on the table each year in federal funding that could support purchases of foods from grocery stores because of folks who qualify for SNAP but do not enroll in SNAP. And another big effort that came out of this was a coalition referred to as the In-Store Coalition, where we brought together partnering organizations from the region that deliver programming and outreach that's relevant to food and cooking and overall health. We bring them in a coordinated way into a grocery store at the same time so that they can deliver their outreach and programming simultaneously. And that way, as shoppers go through the store, they may, for example, go by a table that's doing a brief nutrition education lesson, grocery store tours, health screening. You heard Denise speak just a moment ago. Denise leads one of our health screening teams that's a member of the coalition. They also get SNAP enrollment support and WIC support right there in the grocery store. We've seen that we can have great impact with that in-store approach. So all of these efforts came out of this process of assessment, engagement, and then development of priorities and partnerships to address those priorities. Next slide, please. And the third partnership area I'm going to highlight just briefly is in metabolic health in primary care. This effort started importantly with using collective impact that was driven initially with input from primary care providers in our region. And we've heard from some great primary care providers today during the webinar. You can see how they really have a front row seat to the challenges that are faced within the healthcare system. So we've made a point to listen carefully to what the providers tell us their needs are. With regards to obesity, it started with a request for more training. Physicians and nurses and other healthcare providers do not get much obesity specific training. But as I noted at the beginning of my comments, obesity is a complex disease that requires treatment as a complex disease. Through that training, then we also started to identify in communication with our primary care partners where they had additional needs within the clinic. And by doing that, we developed tools based on input from the providers, and then we reached out to national experts in obesity medicine to develop those tools and make those tools available in a clinic setting. So now we're at that implementation stage where we're working with those same primary care partners to implement tools like our clinical decision support system, which is a training algorithm, our treatment algorithm that providers can use, and Small Changes, which is a web-based app that takes the tailored diet planning off the plate of the provider, no pun intended there, and puts it into the hands of the patient. So the patient goes in and selects menu items that have been developed based on in-depth interviews of people in our region. So they're very border specific to foods that are really preferred here in our region. And all of these tools get used to help drive a more evidence-based approach to treating obesity. Next slide, please. And you heard me mention partners all along the way. This is just a snapshot. There's probably twice as many that I don't even have on the slide, but those partnerships are essential to work together to drive health impact on the border. Next slide, please. And here's my contact information. So if anyone wants more information about the work I've talked about, please feel free to let me know. Back to you, Deb.
Thank you, Leah. Thank you. This is just, I can't tell you how much I've enjoyed your presentation. As we both have talked about, we work on things, but I learned some things that you're working on that I didn't even know. So I think that's one of the things that two things I want to reflect on. And of course, if you have any questions for Dr. Wiggum, please put them in the chat box because we do have just a couple of minutes left. But I think one of the things that we see a lot more, and I think it's throughout but the state of Texas, but especially in our border communities, is because of our geographic location and also sometimes our resources, we have to work together and we have to form these really strong collaborations and really turn to everyone to bring something to the table. So I think that's a commonality that I'm sure we see in Brownsville and McAllen and other border communities, is the need to really create some synergy around lots of partners because one entity can't do everything by themselves.
Exactly. And it's really aligning those partners' work. You know, all the work that United Way is doing is so important. If we can make sure that anything in parallel that other organizations are doing aligns with United Way's efforts, as an example, then we're driving this greater collective impact. So that's what's really powerful. It's hard to do collective impact. Yes. Funding collective impact is a challenge because you need coordination, and you can often get funding for individual programs, but getting funding and alignment for that coordination is so essential. And as I mentioned, we were really lucky when we launched this effort to have strong funding support from the Paso del Norte Health Foundation. And now I'm really fortunate to have strong support from UTHealth. You know, our dean has been incredibly supportive, Dean Borwinkle in Houston, and Dr. Mena, our regional dean here, in ensuring that we have the resources we need to keep this collective impact approach moving forward. So those are all essential support systems.
Thank you, Leah. And again, I agree, a huge, big thank you to the Paso del Norte Health Foundation, who is providing so many resources to our community and serving as just such leaders. And we're very grateful,
absolutely
grateful for everything they do for our community. So thanks to them. So Leah, thank you so much. Again, you have Dr. Wiggum's contact information and her bio in the chat box or in the link that's on the chat box. But thank you, Dr. Wiggum, for all your great work in our community. So, and
thank
now
you, Deb.
I think we're ready to move on to our next panel. And I'm really excited to hear from this piece because we've been talking a lot about maybe some of the challenges. And now I'm super excited to hear from kind of some entities and some partners who are building that stronger community. So this is a panel that includes Jana Renner from the Paso del Norte Health Foundation, and also Michelle Smith, who is the state coordinator, Texas Action for Healthy Kids, and David Gus Kennedy, who's the executive director of Communities in School in Hidalgo County. And I'm sorry I didn't give Jana her title. I know her so well, I just assume everybody does. Jana Renner is the Senior Program Officer at the Paso del Norte Health Foundation. And this panel is going to be moderated by Dalinda Gonzalez Alcantar, who is the CEO of the Boys and Girls Club in McAllen. So welcome to all of you, and I'm going to turn the program over to Dalinda. Thank you. I'm going to see if Miss Dalinda is on. She's having some technical issues. So while we get started, I'm going to get started till she gets on, and then hopefully she can join us in just a couple of minutes. So I'm not sure if we have any slides on this one. I apologize. Let me look at my notes while we are talking. So, and I believe that there are some notes. So I think we're going to start with the Healthy Coalitions, and I'm seeing El Paso and the Paso Norte Health Foundation. So I believe that will be Jana. So Jana, can you kick us off?
Thanks, Deborah. This is Michelle Smith. I'm going to actually
Michelle,
start.
I apologize. Michelle.
No, that's okay.
I was going to give your credit to Jana.
We're together, so we're tag teaming this.
So Michelle, thank you so much. I'm going to turn it over to you.
All right, thank you so much. And thank you all for being here this morning and letting us share information about our work with the schools and the communities and families in El Paso. As she mentioned, I'm Michelle Smith. I am the State Coordinator for Action for Healthy Kids, and I'm joined by Jana Renner, Senior Program Officer with Paso del Norte Health Foundation. Next slide. Just a bit about Action for Healthy Kids. We've been around since 2002. We're celebrating 20 years this year. When Dr. David Satcher declared we had an obesity epidemic, and there were teams from all 50 states gathered in Washington, D.C. to determine how we could work through schools to have an impact on the obesity epidemic. We focused on nutrition, physical activity, and mental health to help children be healthy and ready to learn. So Jana, can you share about the foundation and the great work that y'all do?
Sure, thank you so much, Michelle. The Paso del Norte Health Foundation is located in El Paso, but we also serve 3 counties in southern New Mexico and Juarez, Mexico. We invest in health through grant making, leadership, and strategic partnerships in key priority areas, including healthy living, disease management, and health leadership. The project we're highlighting today touches on all components of our healthy living initiative that are listed here on this slide, but we have a particular focus on healthy eating and active living. Can you advance to the next slide, please? So recognizing that while our efforts to improve healthy eating and active living in our community were having impact through our HEAL initiative, as Dr. Wiggum mentioned earlier in her presentation, we and our partners realized that there was much work that could be done to engage families and students through our schools. So in 2018, our El Paso regional partners reached out to Action for Healthy Kids to create a coalition to work with school districts to educate and engage school staff and parents in efforts to make schools healthier learning environments that consistently promote and support healthy eating and physical activity. The first step was to convene a coalition of stakeholders from school districts and other community agencies. The El Paso Healthy Schools Coalition's main goal was to convene stakeholders interested in school health in order to facilitate a collective voice for healthy schools and develop a school health policy agenda. Action for Healthy Kids has helped us they brought essential technical expertise about school health and facilitated the development of the policy agenda. The organizations on this slide were part of the initial group that met at the beginning of the initiative. Can you advance to the next slide, please? The first year of the project, we identified 3 school districts to work with that were partners that we had been working with for a while: El Paso ISD, Canutillo ISD, and Isleta ISD. We asked them to provide wellness policies and answer specific questions about the health of their district, including school meals, nursing staff, policies around nutrition and physical activity, school health advisory council information, and how they were implementing coordinated school health. And I'm going to pass this back to Michelle so she can talk a little bit more about these assessments.
Thanks, Jana. So the first phase of the project was assessing the school districts and convening community partners to develop that agenda Jana mentioned, with emphasis on making policy change and engaging parents and families in healthier learning environments. The assessment we mentioned included meeting one-on-one with district leads and other team members from the district that had an impact on school health, including child nutrition directors, school nurse, physical education directors, and Action for Healthy Kids reviewed the district wellness policies using the WellSat tool that Leah mentioned earlier to identify any strengths or any challenges the districts were facing. We also looked at parent involvement and whether they had recess policies, how they were involved with community partners. We discussed their school health advisory committees, which are a way for parents to have input into the health issues at schools, and identified how many parents were involved, how often they met, what they were potentially working on. To determine how well policies were being implemented, we went to the campuses and they completed something called the School Health Index, which is a CDC measurement tool that Action for Healthy Kids has modified slightly and has their own version to measure nutrition, physical activity, and social and emotional well-being at the campus level. So then we went back to the districts and shared findings and started talking about what type of solutions they would have. Next slide. What we found basically in that initial assessment was that the shacks were not very strong. They didn't have a lot of parent engagement, and the policies were missing around a lot of different areas. Community partners were available, but not very well engaged in a lot of cases. And the wellness policy language overall was fairly weak. Next slide. Our first meeting as a coalition was about sharing. Both school districts and the community were in attendance, and each shared how they were working together, what their challenges were and what their successes were. And it was really an eye-opening experience. The community members also shared resources that they had that may or may not have been accessed by school districts. After that initial meeting, we continued to meet and reviewed the assessments of the districts with the coalition, talked about areas where they did need support and how community members could help fill those gaps, and then encourage the community members to participate in the school health advisory councils. We discussed the importance of policy to support the change and the need for a healthy policy agenda. The group identified key issues to focus on with input both from the districts and the community, and a policy agenda was developed. Action for Healthy Kids researched and provided best practices that aligned with the areas that were identified. Next slide. The 4 areas that were identified were recess, the need for physical activity, particularly in elementary schools, was a universal theme across all 3 districts. Healthy school meals for many students, particularly in lower income communities. School meals are essential to having nutritious food and making sure students are not hungry. Safe routes to school. Initially, this was a subset of physical activity, but with several fatalities in and around schools, it was determined that the coalition should focus on safe routes to school and recess separately. And joint use agreements, which helps make sure the community is able to utilize school facilities and stay active, particularly with families and children needing safe places to play and be active in different lower income communities, and make sure the district takes advantage of the opportunity for community resources that could be also participating with those joint use agreements. We've provided resources and workshops and support for the first 3 districts and added 3 additional districts to the project since we began. Next slide. This was on the agenda for our first Healthy School Summit, just to show what we worked on after that first 8 months and we did our first summit. We focused on the whole child model, school health advisory councils, the importance of wellness policies, recess strategies, school meals, and shared a successful Safe Routes to School program from Pasadena as a model for where we would be able to take things in El Paso. And these were all the focus areas from our policy agenda. The districts were asked to bring a team to discuss the current situation for those areas with their staff and then review their assessments, and were given time to start making some plans around how they might be able to improve on these areas. Next slide. At the end of the first year, there was considerable progress with our first 3 districts. These are some of the bullet points from the El Paso ISD on where they made improvements in that first year. They did do a WISC whole school, whole community, whole child model crosswalk. They developed a district team and participated in our Action for Healthy Kids Urban School Wellness Coalition. Food Nutrition began piloting outdoor kiosks to help with their access to nutritious food and encourage high school kids to participate. There were several other things that the Food and Nutrition Services worked on. Their School Health Advisory Council actually developed and approved a recess policy in that first year, which was very exciting. And then they were able to appoint a parent as a co-chair for their School Health Advisory Council, which they did not have previously. So all of these are exciting improvements within that district that can help make a change for a healthier learning environment. Next slide. I'm going to turn it back over to you, Jana.
Thanks, Michelle. So as Michelle mentioned, we have added 3 additional districts to the project. Other things that we've added to this work is regular networking meetings with PE departments in these districts and nutrition departments, so they can come together and share best practices, particularly during the pandemic, and share resources. We've also created a separate work group for Safe Routes to School, which is aligned to a Complete Streets Coalition. Next slide, please. So at the end of 2021, after a year of the pandemic, we were concerned that our work might have been derailed a little bit. But in our end of year survey, we were still showing some positive improvements in the school districts. At that time, we only had 5 districts on board, but we saw continuous improvements in SHAC engagement and continued support from district administration for Healthy Kids programs. Just a quick note, the district that did not report positive change had just joined the project a few months before this evaluation took place. And so we hope that we see that district reporting more positive results this year. Next slide, please. So as we move forward, we're keeping the coalition together, but making more efforts to network with school districts and community groups and focus on our work group engagement in Safe Routes to School and other areas to promote child health in our schools. Henry Ford said it best: coming together is a beginning, staying together is progress, and working together is success. We feel we've been successful in creating positive school environments for children to be healthy. Next slide. I'm going to turn this over to Michelle to talk about a great opportunity that's coming up.
One of the things that the community asked for as part of our coalition was to understand how to be better advocates around school health. So we had a session in March around Advocacy 101, and now we're doing a workshop around advocacy on key issues that we're working on. We have Safe Routes to School talking about their programs and how to advocate around key issues around safe routes. We have American Heart Association helping with advocacy around vaping and tobacco prevention. And then we'll also talk about the importance of school health advisory councils and engaging parents with the PTA. So we will put this link in the chat if you're interested in signing up for that session on April 19th. Next slide. And I think that's our contact information. And if there's questions, happy to answer. Did we ever get our...
So I apologize. I think Dalinda has joined us.
Okay.
So
yes, how are you?
Yes, I'm going to turn it over to Dalinda. Welcome, and I'll let you continue. Thank you.
Great. Thank you so much. I really appreciate that. That's really motivating to see what the coalition is doing. And it's exciting to see the growth and the expansion. I can't wait to hopefully work with you here on the border in South Texas. I noticed that one of our shack extraordinaires down here in the Rio Grande Valley is Mario Reyna, a great friend of mine. I noticed in 2018 that he was actually part of your conference and discussion. We are sad that he has retired. He's enjoying himself, but he's still very active actually at the Boys and Girls Club with me and is a mentor for many people down here in the region when it comes to a healthier school. So that's exciting that you guys have connected. You know, one thing that is specifically for Michelle and Jana is, you know, how do you really, or what are your plans to begin to expand into other areas, and how can everyone, you know, get involved in that expansion?
So we are working in New Mexico as well. That was one of the things we did, was take this across the state line and working in Las Cruces and Doñana County. And so each community is different. So, you know, taking the model of collective impact and working through coalitions. We would love to move into Rio Grande Valley. In fact, I've talked to Mario a bit about that. Because of his work there and how he could help us maybe do something in that area. And we've also looked as Action for Healthy Kids at East Texas as well.
Great. We'll have to have conversations offline about that. Our shack was also growing in this region pre-pandemic. And so I think, you know, I think we can all agree that the time now is even more imperative because of the effects that the pandemic has had on the health of so many of our children on the border. So we can definitely connect offline. I appreciate that. Yeah, for sure. And what about you, Jana? What are your thoughts on expansion? Where do you see this going?
You know, we've talked a lot as we have a steering committee as well. And I think the pandemic has opened up the need to make sure for learning around social emotional health and bringing in, and we have brought in some speakers around that, but continue to explore how the coalition and our community partners can support schools in that area.
Very cool. And I'm going to kind of segue a little bit to Gus, but prior to that, you know, I do completely appreciate all of the work that's happening at a school level with school districts. And of course, me at the Boys and Girls Club of McAllen, our focus and expertise is actually out of school time, right? So anytime that the children aren't in school, then that is considered out of school time for us. And some, you know, Boys and Girls Clubs across the country, but namely for this discussion here, you know, on the Borderlands, there's a lot of really great work that is happening out of school time that we have measurable impact. So a lot of people don't know that Boys and Girls Clubs actually have curriculums very much focused on minority and at-risk communities. And As many know, I'm here, in the South Texas border region, we really struggle a lot with obesity that then oftentimes leads to diabetes. And so some of the work that we're doing and that impact is actually with curriculums called Healthy Habits. There's a lot of movement, right, and physical activity that happens when a child goes to the Boys and Girls Club to help to combat that obesity. We have a very strong partnership, as do many clubs across the border, with our local school districts for food programs. And so here at the Boys and Girls Club of McAllen, we actually partner with McAllen IC. And then when we talk about the social emotional component of several clubs here in our region, we actually have licensed social workers that are working to combat that physical component as well as a social emotional. And so it is exciting to talk about the, school time and the out of school time. But Gus, specifically to you, I was wondering if you could tell us a little bit more about how you all address obesity, nutrition, physical activity, and really the whole child, which is similar to what clubs across the border do as well.
Hi, Delinda. Good luck with your election, and tell when you see Mario, tell him that Gus Kennedy said he was one of the worst basketball referees I ever worked with.
I will not be telling, hey Gus, I will not be telling him the latter because he actually volunteers his time to get me referees for our high school basketball program. So I think the volunteerism, it would stop if I mentioned him. I'll tell him you said hello.
All right, he's a good friend of mine. I'll go too fast. This has really been fascinating listening to all of you. And I'm just going to tell a couple of stories which will resonate with all of you and what we're talking about. This is about 12 years ago, and this is I'm not going to tell you what school district is in. We run summer programs, and one of them was theater at one of these middle schools. And I was I went to the program, and I participate in the summer program, so it keeps me involved in this program for what we're doing as far as like the social emotional part of this. So the theater is for at-risk kids, and they excel in it. Have a lot of problems with it. They get on stage, they cuss, they steal, they do all kinds of stuff. But the lunch part of the school, we were in school and we're getting school district stuff, and we affected this thing only by bringing it to the school board's attention. And we were all sitting there, and I get up to empty the barrels. There was what, 200 kids involved in this, and the barrels were overflowing. When we went to throw them out in the dumpster, it was so heavy, it looked like all their food was being thrown out. So one thing you all know with kids, if the food tastes awful, they're not going to eat it. I'm not going to eat that. And so I walked into the kitchen and I asked one of the preparers, I said, what is this? And she told me that it was a fish sticks. And I opened it up and it was like chicken. And they didn't even know what they were putting it. They were just throwing it into the plates and stuff. Anyway, so it was like, get this food out of here. The expiration dates on some of this food were like 6 months off when you looked on the packages and stuff. So we went before the school board. We did that. They initiated this big deal. They brought me in to talk, and I didn't know a damn thing about food, but I found out a lot about food and how it was being distributed by the federal government. And they made a great improvement in that. And so now one of the school district that we're in, we have 37 schools in there. We case manage about 6,000 kids there. Case management, that means we have them all the time. And they changed the food delivery system. So now they have breakfast, they have lunch, and they can stay there after school. And I wish we had some real good, strong boys clubs like we have in McAllen over that area. It's like light, but they're getting 3 meals. But during the pandemic, of course, it just collapsed. That whole system collapsed. A lot of the kids were staying home. A lot of the kids are, not even paying attention. They got computers and stuff like that. Some of the kids that I talked to in focus groups were talking about they watch porn and they're not paying attention to the teachers and stuff. So it's been a complete disaster, that thing, especially for the kids that are at risk of dropping out of school, which leads, obviously you all know, but if you don't have education, you end up buying fast food. And so the Valley is full of that. Outside of the school system, there's very, very little, attention paid to what people are eating over here. And that the obesity problem, and Delinda will tell you that the people walking around the Valley, I think it was nationally one time, they were showing just the bottom halves of people's legs. And that problem exists because of poverty, because of ignorance, and then the education level of our whole Valley is such that food is not something that people that are limited with financial resources are gonna pay attention to getting vegetables and fruits and different things like that. That I would love. I hope you do come, Michelle and Jana, to come to the Valley. It would be a great partnership with us. CIS has, over the years, I've been here for 32 years. It seems like I've been here for 80 years. That's what my staff told me too. But we're limited in what we can do. And there's so much of a need to do both the mental health aspect of this and the food aspect of that. They're both connected. And how do we do that? And it's been one problem after another. And I'll leave you with this because I've talked too much. I work in my bio. I worked for the last 8 years. I've been working with the Department of Justice and the Department of Defense for counseling for soldiers. A lot of them come from the Rio Grande Valley, but it's international. And the sum and substance of that whole thing is like, how do we provide these kids that are coming from like places like the Valley into the military? They're carrying all this stuff into the military. And now we're finding out that all that stuff that they went through, the poverty, the food, the mental health aspect of living in a place that has the cartel, it has all the things that are awful, especially in some parts of like Western Hidalgo, where there's, if you can imagine what's going on here now with now we're getting ready to have another influx. I talked to Chuy Hinojosa, who's the senator here. He said that we're probably looking at another 500,000 to 1 million people walking in as soon as they lift that CD thing. That money that's coming to support that is coming directly from the taxpayers in Texas. We're not getting any money from that, from the federal government. So when everybody complains about our Governor Abbott says he's going to move all these people by buses into Washington, D.C., why not? I said, if the taxpayers here, and more importantly, if the Valley people who are already like 50% of the people here, and Delinda will tell you, live under the poverty level, and we have to pay for that? Are you kidding me? That's going to come from somewhere, and I'll bet you bottom dollar that money is going to affect what kids are eating in school. Last story, I brought some of these military people in here 2 years ago, right when the pandemic started. There was 35 doctors, and they came out to, I'm not going to tell you where this, but it was in Western Hidalgo. We allowed all the teachers and all the parents to know that we're going to come. We expected to have like 15 to 20,000 people over a 3-day period. First day we go there, there's nobody there. There's nobody there. What the hell is going on here? We did all this preparation. And what happened is about 1.5 miles away from that, there was a raid, and I'll leave you with this. There was a raid at this mom and pop grocery store by the Border Patrol, who we tried to keep away from this because a lot of like undocumented people go to these things. And there were 211 kids being ready to be child trafficked to Houston, and a lot of them were in my program. And so we're dealing with that. The Texas legislature fortunately gave us a whole bunch of money to do this Texas-wide. We have like 28 programs, affiliates that are all working in different aspects of this. But the food, all that stuff is connected, and those kids were going to be trafficked, and we have that here too. So congratulations to everything that all of you are doing, and I love seeing your faces on here. Sorry, I would have had my my Hollywood picture, but it was unavailable at the time with this filming.
Yeah, no, and thank you for sharing. It's definitely extremely complex. Also living here in McAllen, and there's so many things that are happening, but keeping children at the forefront, regardless of what country, I think is important. I think we can all agree on that. And it is also difficult with, one of the things that we're having a lot of discussion about here, and actually nationwide, is going to be just the cost of food. So for those that were already living in poverty, being able to fill the bellies of a child with, was difficult already. And then with this inflation, but, I think we all know on this conversation, just the value of healthy eating and how that actually helps with mental health, and helps to, even for a child to learn as, in the best that they can, eating well is something that we don't discuss very often, with the correlation between academics and healthy eating and healthy living. And so, this goes back to Michelle and Jana. If you could maybe specifically talk about either some trends or some discussions that you all are having, when there is that direct correlation between healthy eating, healthy living, some anxiety that you're maybe seeing, and some just mental health concerns that were exacerbated by the pandemic.
Michelle, do you want to go first? I think you have more information.
It's been a very
Hey, gentlemen,
challenging.
let's discuss one more time. Michelle, before you start talking, a shout out to all our food banks here and all the pantries that we have in all these schools, because without that, we got nothing. But thank you to all the food banks in the state of Texas.
Absolutely.
So it's been a challenging 2 years, and frankly, I think the second year of the pandemic was worse than the first. You know, our physical education teachers are exhausted. Our child nutrition directors and their staff are, you know, just at the, you know, end of their rope. They've had supply chain issues. They couldn't get the foods that they needed to serve healthy meals. They've had to change menus. They've had staff out sick. They've had to cover, you know, staff from one school to another school. Just trying to keep things going and just moving forward has been so challenging. We did a summit in November and had a panel with the child nutrition directors talking about things that they've had to try to cope with and how solutions they've come up with to get around things. But they are true champions and heroes, all of them, to make it through this and continue to work with the food banks and to work with the community to get food out to the kids that were stuck at home virtually, to get food out. You know, and one of my PE teachers even went to the kids' houses and put stencils on the sidewalk outside so the kids could be active. I mean, you have a lot of dedicated people that have really worked hard to get through this pandemic, and we really hope we're coming out on the other side.
For sure. No, absolutely. And as we wrap this portion up, Jana, if you can close this off, and, you know, it's a question I think is really valuable. What do you think should be top of mind for all of us? You know, the important thing to consider when you're really trying to build a better place to learn. What do you think should be top of mind for us?
You know, that's before the pandemic. Yeah, when we started this coalition, it was always like, we need to drive home that connection, like you were talking about, between healthy foods and physical activity and mental health, and even creating an environment where kids can learn better. And then the pandemic came, and you know, they're stuck staring at screen, you know, the opposite of all of the things that we were trying to advocate for. So I think it's bringing those things back, but also taking the learnings from the pandemic and adjusting and making sure that we're flexible and not ignoring what we learned through the pandemic, because it's not the same. And so, you know, we're still learning how we, you know, this, like Michelle said, I think that this year has been even harder. And so I feel like when you're working with a lot of people who are just trying to get through it,
that's right.
Bring these other things, they don't seem as important, but they are now more than ever. And so it's bringing all of those lessons back, but making sure we're adapting them and making it relevant to now.
For sure. And you know, I want to close off with this thought, and it's something that you said that's kind of been thematic as for all of us that are in leadership here on this discussion. I think for about 2 years, we were literally trying to survive. So survive. And now I think we can begin as leaderships, and this is a call to action to everyone, that we can get to a point to begin to be very future minded once again, to be future minded and to really think about some of these initiatives that were pre-pandemic and begin to adapt and adjust them for our children. So, you know, being able to have the privilege of being able to be future minded to help those that are still surviving, I think is what is really valuable and necessary for all of us on this discussion. So I want to thank you so much to all the panelists for joining us today, the incredible work that you guys are doing. I'd love to see you in the Rio Grande Valley soon.
Thank you, Delinda. Thank you so much for leading us through this incredible panel. And again, also echo the thanks to Jana, Michelle, and Gus, again, that committed work that they're doing. So appreciated. I also want to thank all of you for staying with us. You know, this has been some incredible knowledge sharing and inspiration from so many individuals in border communities throughout the state. So thank you so much for staying with us. And we really are excited to really now present a discussion on the intersection of health and environment, which is maybe for many of us not the first place we go to when we think about children, health, and border communities. So I think this is a really important topic and discussion for us to be having. So with that, it's my pleasure to introduce this panel, and it is Dr. Juan Antonio Aguilera Mendoza and Ursula Kripa and Stephen Mueller. And let me give you their titles, or let me give you what they're associated with. So Dr. Mendoza is a staff research scientist at Stanford University. Mr. Mueller is the architect and founding partner of agency and director and associate professor at Texas Tech College of Architecture right here in El Paso. I'm always proud when I can say those words. And Ursula Kripa is an architect, founding partner of agency, and director and associate professor also at Texas Tech College of Architecture. So Dr. Mendoza, I'm going to have you start making your presentation, and then we'll flip it over to Ms. Kripa and Mr. Mueller.
Thank you so much, Deborah. Can you hear me okay and see my slides?
Yes, yes, thank you. Thank you for joining us.
Excellent. No, thank you for your introduction, and thank you all for being here and being able to participate in such an important topic. I think the work that we're all doing collectively to help our community, it's essential, and by working together, we can find better solutions and better partnerships. So this is already a great success given the amount of people interested and the participation. So hopefully we'll be able to answer some questions at the same time as clear some of the air regarding what things can we do at the environmental level. As you mentioned, the intersection of health and the environment is really present, and this is going to be part of some of the work I started doing while doing my doctoral work at the University of Texas at El Paso. So I'm going to start focusing on some of the findings we have from a project that look at the associations of traffic-related air pollution and the things we found regarding physical activity for children with asthma in our community. So the problem here is that air pollution is ever present. I mean, 43.5 million are exposed to traffic pollution in the US, and this means living within one block of a heavy traffic road. And sadly, this is more likely to affect underserved communities, and our borderlands are no stranger to people that are living within underserved areas. The abundant evidence of adverse health effects is already present, and we've seen that there's an increased mortality due to cardiorespiratory complications with the exposure to air pollution.
I'm presenting at this conference thing right now.
So I think the heavier issue we have with heavy traffic air pollution is the association we see with children and adults for respiratory diseases, diabetes risk, high blood pressure, high cardiovascular disease. I mean, the particles that are present in pollution are so small that are even smaller than our own blood cells. The issues go beyond what we breathe in as far as the respiratory tract. These particles are able to diffuse through our lungs and get into our bloodstream, and then on the long term create havoc for our system. We're starting to see that cardiovascular problems tend to emerge over time. There's been relationships with diabetes, and World Health Organization has mentioned that right now about 8 million deaths yearly can be attributed to air pollution. For our children, this is very concerning because even living within 30 to 300 meters from a major roadway can give us significant issues regarding cardiovascular health, arterial stiffness, decreased academic performance. They tend to go less to school, and an increase of clinical symptoms, in particular for children with asthma. Air pollution in El Paso, I mean, I was born and raised in Ciudad Juarez. I finished my medical degree there. Then came to El Paso to do a master's in public health, where I started some of the work relating to air pollution and how it affects our communities, our children. And the biggest issue is that given the desert area, it's very difficult to comply with the requirements to have less particles in the air. in particular those particles that are larger because of how many dust storms we get in the outskirts of the city. But also the traffic emissions from the border crossings make a sizable portion of total vehicle emissions we see in El Paso, with also some compounds like nitrogen dioxide being emitted by heavy traffic pollutants and trucks and diesel trucks. And this is an issue because, as we know, in the border bridges, cars can be idling for up to 4 to 6 hours. And this is going to be an increased source of pollution, not only for the people that are commuting, but also for the people that are living nearby. And even some of the children attending some nearby schools that are very close to heavy traffic roads. In this regard, ozone is also everly present throughout the region. And it has been a huge source of pollution in our area. What does this mean for exposure to air pollutants and physical activity? Well, the benefits of physical activity are essential for overall health, and there has been an increased benefit and a contrast with air pollution. So the thing is, doing physical activity, performing physical activity, it's gonna decrease our chances of cardiovascular disease and decrease metabolic syndrome. But also the effects of outdoor physical activity, it's gonna be an ever-present exposure to air pollutants. And in this regard, outdoor physical activity exposes people to air pollutants, and this might lead to increased cardiovascular disease, respiratory diseases. For children with asthma, it's gonna increase the risk of having an asthma attack and increase lung pathologies. So what did we do in our community? Well, we paired children from a school that was near a heavy traffic road with a physical activity monitor. We wanted to objectively measure their movement and see how much time they will be spending in physical activity. Through these devices, we were measuring their movements, if their increased activity was moderate to vigorous, if they were having light activity, or they were basically in sedentary activity. And of course, we paired this with other measures that had to do with respiratory health, lung function, and fruit and vegetable intake. This is what's very important because, as you can see, this is an image where we worked at a school that's very close to a heavy traffic road. The monitors for air pollution were located within school grounds, and you can see that right out the fence, there's already a gateway street that connects to a heavy traffic road in El Paso. So we monitored the physical activity for children in the period of 10 weeks. We basically went at the end of every week and paired them up with the monitors for activity. And then our partners from the University of Texas El Paso measured the air pollution activity at the school grounds over time. So every week we would assess the amount of time the children spend doing physical activity while at the school grounds, and then do an association with the amount of air pollution that was present at the school grounds. We wanted to see if, for example, during days that the air pollution was a little bit heavier, the children will be spending less time performing physical activity. These are children with asthma, so the respiratory tract, it's already impaired in a bit because the increased particles would trigger some of the asthma, and for some of the children, this is very concerning. The biggest finding was that moderate to vigorous physical activity levels negatively correlated with the traffic-related air pollutants in the children with asthma attending a school near a freeway. What this means is, as air pollution tended to increase overall within the school grounds, the children with asthma tend to spend less time performing moderate to vigorous physical activity. And these associations, surprisingly, were not necessarily associated with the air pollution that was present a day before. It wasn't until we assessed what was the air pollution 3 days before, 4 days before, that we start to see a significant change in the amount that the children will be spending in physical activity. This is basically telling us that given recommendations to perform physical activity outdoors based on the pollution levels a day before might not be enough for children that are having asthma. We need to consider what is the overall trend of air pollution. For us, it took us about 4 days to see a significant change, which basically means that for children to be less active physically, they need to be experiencing basically not just a bad day of air pollution, but a bad week. So if the air pollution is severely present in these outdoor areas, what can we do? And this has to do with some of the associations we did, but also the characterization of this. Physical activity, it's very difficult to assess if we just rely on what our participants report. We were proud to see that in this study, we were able to measure the physical activity directly with the children, thanks to their willingness to be using a monitor. But also, what can we do to change our built environment? This becomes the overall message I want everybody to take home from this presentation. Changes in policy, of course, can be having a definite impact with changes to the outdoor activity schedule, to changes in transportation to school policies, to decrease vehicle lighting, and planning for better schools to not be heavy traffic roads. But the placement of natural barriers, how can we go at the community level from an environment where we have basically no protection from outdoor air pollution to better barriers that can protect us to air pollution? The placement of natural barriers that mitigate the exposure of air pollutants, it's a crucial thing that can be done at the community level, because we can advocate for more green barriers, for more trees that would supply us with better interceptors for the pollutants, at the same time that will provide a better built environment for our children. In this sense, having environments where we intersect the community environment, the built environment in the cities with more nature, with more trees, will offer us trees with shade buildings that will be reducing the need for air conditioning, reducing fossil fuel combustion, the absorption of particulate matter from the air that will coming from the heavy traffic roads. And also, large and healthier trees will give us a reduction of the effects of air pollution removal and better oxygenation. So in this sense, there are things that can be done at the local level. There are things that we can do at our current environment to protect our children and to improve not only their overall health, but the amount of time they will be spending at school, the amount of time they will spend doing physical activity, and overall less effects of air pollutants. And for this, I would like to acknowledge our partners from the University of Texas El Paso, the School of Public Health Center for Community Health Impact, and the Center for Transportation Emissions for Energy and Health. And thank you so much. And with this, I would like to pass it to Ursula and Stephen.
While we wait for them to get on, I want to thank you, Dr. Mendoza, for all your great work. And we're sorry you're not here anymore, but El Paso will always be home for you, we know.
Thank you so much.
Hello. It's so nice to be here, I've been so inspired and humbled by all the amazing work that's being done. And also, strangely, we're the only architects in the room. And so we figured we have some visuals to show. So I'm going to share my screen, and I hope you see it. Whoops, that's the wrong thing. Here we go. Okay, so yeah, as was mentioned, we co-direct POST, which is a research center at Texas Tech University at the College of Architecture in El Paso. Very proud to be located in El Paso and to kind of think of this region with you all today. In the research center, we look at intersections between climate change and the built environment, and how the built environment creates these kinds of dangerous or inequitable kinds of spaces. And so we look at environmental air quality, water access, UV exposure, again, through this lens of design for the built environment. And we also design tools and prototypes to better mitigate these issues issues. So today we're going to show a project that's a prototype for protecting children during outdoor classroom activity. I think this really kind of connects well with the previous presentations where the discussion about outdoor activities in relationship to health has so much to do, through our findings, has so much to do with being in the Chihuahuan desert. Where there are organizations who are trying to bring kids out into outdoor learning environments. However, the harshness of UV exposure and other environmental impacts, as Dr. Mendoza just showed, is present. And so what can architects do to kind of protect children in these outdoor spaces? So Stephen will start with kind of the data and the research context for this region, and then I'll talk a bit about this outdoor safe classroom that we're working on.
So hi everyone, I'm really happy to be here as well. So yeah, I'll start by sort of explaining the kind of back end of the project, like how we uncover the issues and develop tools to address these issues. So just some context first. There are shifting patterns of ultraviolet exposure in North America that map very closely to our borderland environment, as you see here in the UV exposure risk maps, where the high intensities sort of collect along our particular geography. But the lack of shade in the borderland and particular features of the landscape, like those that Dr. Mendoza just mentioned, this high degree of airborne particulate causes atmospheric scattering from airborne dust that increases the health risk to individuals from ultraviolet sort of being scattered throughout our environment. So this project is really to build awareness to these issues and develop tools to understand these risks and develop mitigation strategies. We see that shade itself is actually unequally or asymmetrically distributed in the borderland, as you see in these images. A number of different vulnerable populations, including children, but also migrants and migrant children, are particularly underserved as they inhabit the borderland. The EPA has identified the 30th degree north parallel as a kind of geographic limit of the northern boundary, below which there is an increased risk of ultraviolet exposure over the next decades. The entire borderland, you'll see, falls within or very close to this line, and the particularities of our atmosphere actually extends the zone, I think, across the borderland. In the research center, we've been developing GIS and computational tools to map these conditions, which are otherwise pretty invisible. So we're developing shade surplus, shade deficit, and what we call irradiated shade maps using remote sensing and other tools. The data that we have available in the borderland for these types of mapping approaches is actually pretty disjointed and discontiguous. And so the research center is really invested in developing tools that sort of bridge data and environmental data across the borderland through the use of things like remote sensing. So I'll just scroll through some slides really quick, showing some of the maps that we developed, which outline the diffuse and direct radiation exposures here near the pedestrian bridges in El Paso and Ciudad Juarez. So red areas are high risk and yellow areas are lower risk. You can see a zone of increased intensity where there is a high level of pedestrian activity, for instance, near the pedestrian bridges. And just kind of scrolling through these maps, we correlate these maps to, provision of vegetation, the location of different pedestrian activities, including where public transit stops and things like that are, to try to identify where there are different populations, including school children, who are inhabiting the areas of sort of highest risk, so we can determine sort of where to invest resources against some of these threats. Here you can see, for instance, a pretty low risk area in the developed downtown core and a very high risk area near the bridges. So really quickly, some of the tools that we developed to model and map borrow from some of the logics that are otherwise pretty invisible in tools like GIS. But one of the things that we discovered is that you can be within shade and think that you're protected from ultraviolet exposure, but because of the degree of atmospheric scatter, shaded conditions in our environment are actually highly irradiated. And one of the physical things that determines how irradiated shaded conditions are is actually how much sky exposure you have from any point within the city, meaning as you look outward from any point in the city, how much sky can you see? So we've been developing using 3D modeling software and computational tools, we've developed these things called sky exposure catalogs, which can take any point in the city and map the degree of exposure to this diffuse radiation that threatens conditions of apparent shade. And we're able to then correlate that with data from, different times of day that have increased levels of threat and things like that. So real quick, some of these maps that you're seeing are color coded. So every intersection within the borderland has been sort of mapped through our algorithm to identify the geometry of exposure, but also the relative risk of exposure of each of these intersections, some of which, involve the kind of pedestrian activity of children attending school. And yeah, I'll just leave it there.
And so really quickly, what do we do about it, right? How can we think through this through the built environment lens? And so we're lucky to be working with Insights El Paso, which is located at the dinosaur tracks here in El Paso, where conditions like these, right? This is in pink, you see here, this is the kind of the beginning of outdoor classroom experience for kids, where through STEM programming and kind of fossil digging and fossil learning, hands-on programming. And so you see there isn't any of that shade that Stephen was just mentioning, or any kind of green area to protect against irradiated shade. So you get these kinds of conditions, kids out in the sun trying to learn. So this is the project site. Again, you can see it's relentless and there's no way to be hiding from. And so what we've been doing is kind of looking at ideas of these sort of fragmented ideas of structure that might become also as dual shade kind of surfaces that are built out of a specific aluminum material that we've been working with for years now that is able to block kind of thermal gain. And so to think through this, we've been thinking through this in terms of the geometry and an outdoor classroom amphitheater type of environment where there are multiple classrooms. As you see on the right is kind of the ground, smaller spaces where kids can break out into groups. And so the idea is to mitigate both like wind kind of that needs to uplift or move through the structure, but also to deal with the geometry that Stephen was just explaining of how much sky exposure there is, and to sort of protect against that kind of UV damage in outdoor learning. And so we're hoping to break ground this summer and to use this as a kind of learning experience that might also be paired with environmental data that kids can read along the structure to understand what it means to be in this irradiated shade condition. And so some kind of ideas might look like this. Thank you so much.
Thank you all so much. We are just inspired by that, and it's and I live here and I'm so excited when I learn new things. So it's always wonderful to hear from you all. And we are coming up onto the end of our time together, but I'll make sure that we have any questions. Let me look real quick if we have any questions, or if anyone wants to pop a quick question into the chat box. So let's just see, again, lots of thank yous. And then we have one thing, that 2 high schools and a middle school in the elementary area with stones off the border is so significant that I worry for their children's house. Unfortunately, for most, they are economically unable to live in other areas. So what are your thoughts on that?
Well, I think as architects and urbanists, I would, that's a real issue. And instead of hoping to move and to leave areas behind, right? We also have this brain drain, as it's being called in El Paso, people leaving us. I think it's on us as architects and designers and city policymakers to think through the built environment, as Dr. Mendoza mentioned, in terms of zoning, in terms of where schools are located, what are parks and green belts that are sustainable in the desert that we can use, but also to really think equitably about the built environment, and not just to answer a client's questions or a city's questions, but to think about, okay, who is not at the decision-making table, and how do we kind of think through all of these sort of marginalized issues that have never come to the forefront of how we design.
Great, I love that. That is such a, yes, 100%, thank you. So I want to thank the last panel. I certainly want to thank Ms. Crippa and Mr. Mueller and Dr. I was gonna call you by the wrong name. So by Dr. Mendoza. And I want to thank you so much for this panel. It was really an interesting discussion. I'm going to turn this back over to Sharmily, but before I do, I want to thank all of you for staying with us for such a long time. Again, lots of food for thought, and thank you to everybody that's doing the great work in our communities and to all these leaders we heard from this evening. So it's from today. So how do we, I'm going to turn it back over to Sharmily, and thank you all for being with us today.
Thank you, Deb. What a tremendous whole summit, right? Sessions, all these different interesting panels. So thank you everyone for joining us today. We had a dynamic cross-section of speakers throughout the morning until now, speaking on children's health and well-being and sharing some very innovative interventions and ways of implementing strategies tailored for the communities and their nuances. So we hope to continue these conversations beyond today and collaborate and support our children and families. So get in touch with Children at Risk and the Texas FLC teams using the information on this slide. And again, thank you to our sponsors, partners for this event. Join us for the Texas FLC and Children at Risk's next virtual summit, the Texas Motherhood Summit on May 5th from 10 a.m. to 1 p.m. And it's going to explore everything from prenatal care to child care and mental health, economic justice. And this virtual event will celebrate motherhood while unpacking policies, lifting them up, bringing them down. Our event technicians will drop the link and you can learn more about this. We urge you, and as last request to all of you, to share your feedback with us so that Children at Risk and Texas FLC teams can continue to bring you not only more relevant and engaging conversations, and you can use this QR code to scan, and the link will be dropped in the chat as well. So again, thank you to all of our speakers and panelists. So appreciate your sharing your expertise and taking the time today. And with that, we will close out.
Thank you.